I would like to welcome everyone to International Conference on Medical and Health Science 2023, conducted by Medical Faculty, University of Muhammadiyah Malang. May I have a round of applause for all of us today? Boleh kita berikan tepuk tangan dulu Bapak Ibu? Terima kasih banyak. Thank you. It's an honor and privilege to me. My name is Rahmania Santoso to be the master of ceremony for this loving morning. And first of all, please allow me to express our gratitude and warm welcome to the Honorable Vice Rector of Academic Affairs, University of Muhammadiyah Malang, Professor Syamsul Arifin MSI, who already joined via online Zoom meeting. And also the Honorable Dean of Medical Faculty, Dr. Medi Setiawan, SPPD Finasim. Dean of Health Science Faculty, Dr. Yoyo Bekti Prasetyo, MKep SPCom, and currently he is at Makassar. Head of the Committee of ICMedH 2023, Dr. Rubayat Indradi, Master of Occupational Health. Our speakers, Profesor Ali Gufron Mukti PhD, CEO of BPJS Kesehatan, and today represented by Dr. Doni Hendrawan, Master of Public Health, Mr. Febi Dwi Rahmadi PhD from School of Medicine and the Indonesian Program Coordinator for the Center for Environment and Population Health, Griffith University, Queensland, Australia. Profesor Dato Dr. Muhammad Husni Jamal, DNBS, President of World Organization of National Colleges, Academies, and Academic Associations of General Practitioner, Family Physician for Asia Pacific region. Professor Goh Ligan from Division of Family Medicine, Yong Lu Lin School of Medicine, National University, Singapore. Professor Dr. Ignatius D.A. Sutapa, Executive Director, Asia Pacific Center for Eco-Hydrology, UNESCO Situsi. Dr. Sasmoyo Widito, SPJP, Chair of Indonesian Medical Association, Branch of Malang Raya. Dr. Febri Endra Budi Setiawan, Head of Public Health Department, University of Muhammadiyah Malang. And also, of course, I would like to extend our gratitude to all of the delegates of ICMedH 2023. Ladies and gentlemen, let's begin today's agendas by singing Indonesia Raya National Anthem and Muhammadiyah Anthem Sang Surya. Ladies and gentlemen, please stand up. Indonesia Raya. Muhammadiyah Anthem Sang Surya. Thank you, ladies and gentlemen. Please be seated. Ladies and gentlemen, the next agenda is reciting Holy Quran. Mr. Ruslan Abu Bakar, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. A'udzu billahi minasy syaithanir rajim. Bismillahirrahmanirrahim. Huwallahul ladzi la ilaha illa huwa alimul ghaibi wasyahadati huwar rahmanur rahim. Huwallahul ladzi la ilaha illa huwal malikul quddusus salam al-malik al-quddus as-salam al-mu'min al-muhaimin al-aziz al-jabbar al-mutakabbir subhanallahi amma yushrikun. Al-malikul quddus القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم صدق الله العظيم. Wassalamualaikum warahmatullahi wabarakatuh.
Sadaqallahul Azim. Thank you, Mr. Ruslan, for giving us such a heartwarming Quran recitation. Now, ladies and gentlemen, let's move to the other session of this agenda. I would like to invite Dr. Rubayat Indradi, Master of Occupational Health, as the head of committee, to come to the stage for delivering today's event report.
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, esteemed participants and distinguished guests, I extend a warm welcome to all of you to the 3rd International Conference and Medical and Health of Science, ICMedH, an event of great significance under the theme Global Health Challenges and Innovations in the Post-Pandemic Era. It is truly an honor to serve as the chair of the organizing committee for this conference. First and foremost, I would like to express our deepest gratitude to our esteemed speakers who have graciously joined us today. Your expertise and insight are invaluable as we navigate the complexities of global health challenges in these transformative times. The first is Professor Ali Gufron Mufti, CEO of BPJS Kesehatan, and also his official representative, Mr. Doni Hendrawan, MD, MPH. Welcome to Malang, Mr. Doni. And then Associate Professor Dato Dr. Muhammad Husni Jamal, President of WONCA, Asia Pacific region, and also from Cyberjaya University, Malaysia. Welcome to Malang, Prof. Professor Goh Ligan, Associate Professor from National University of Singapore, from Singapore. Welcome to Malang, Prof. Goh. Mr. Febi Dwi Rahmadi from Griffith University, Queensland, Australia. Welcome to Malang. Professor Ignatius Sutapa from UNESCO. And then Dr. Febri Endra Budi Setiawan, Head of the Public Health Department at Medical Faculty, Universitas Muhammadiyah, Malang. And then the last but not least, Dr. Sasmoya Widito, Chair of Indonesian Medical Association, branch of Malang Raya, and also his official representative, Mrs. Valerina Yogi Buana Swastika Putri, MD, FIHA. I also want to extend our sincere appreciation to LPPI UMM, Lembaga Pengembangan Publikasi Ilmiah Universitas Muhammadiyah Malang, and its chairperson, Dr. Fardini Sabila MPD, for their invaluable support. Matur nuwun Bu Fardini. I must also acknowledge the invaluable support we have received from the leadership of the Dean, Faculty of Medicine, Dr. Medi Setiawan. Thank you, Dr. Medi. And also all the Vice Dean, also the Dean of Faculty of Health Science, Pak Yoyo Bekti Prasetyo, MKep SPCOM, and all Vice Dean. Your guidance and encouragement have been instrumental in shaping this conference into a forum for innovative ideas and meaningful discussion. Last but certainly not least, I want to express our gratitude to the Rector, Prof. Dr. Fauzan MPD, and all the Vice Rectors of UMM for their unwavering support and commitment for advancement of medical and health sciences. Your endorsement of this conference underscores its importance in the broader context of higher education and also research. Today, we have remarkable lineup of those 7 speakers who will share their expertise and insight on critical topics in global health challenges and innovation. It is our hope that this discussion will pave the way for the innovative solution that will shape the future of healthcare worldwide. In closing, I would like to extend my sincere apologies for any shortcomings or inconvenience that may arise during the course of this event. Our team has worked tirelessly to ensure a seamless and enriching experience for all participants, but we remain open for feedback and continuous improvement. Once again, I welcome each one of you to this conference, and I am confident that this knowledge sharing and connection forged here today will have a lasting impact on the field of medical and health sciences. Thank you for your participation and commitment to the pursuit of global health excellence. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rubayat, for the report. Ladies and gentlemen, now let's listen carefully to the remark from the Dean of Medical Science Faculty, Dr. Medi Setiawan, SPPD Finasim. The floor is yours.
Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all. I am deeply honored to extend the warm and heartily welcome to each one of you of the third International Conference on Medical and Health Science, ICMedH, under the theme Global Health Challenges and Innovation in the post-pandemic area. Our gathering today is the testament to our collective communication commitment to advancing the field of healthcare and medicine. First and foremost, I would like to express our sincere gratitude to our distinguished speaker, Professor Ali Gufron Mukti, CEO of BPJS Kesehatan, or official representative Mr. Doni Hendrawan, MD, MBH. Associate Professor Dato Dr. Muhammad Husni Jamal, President of WONCA, World Organization of National Colleges, Academic and Academic Association of Global Practitioners or Family Physician in Asia Pacific region. And then Professor Gohligan, Associate Professor in the Division of Family Medicine at the Yonglo In School of Medicine, National University of Singapore. And then Mr. Febri Dwi Rahmadi, who serves as the Indonesian Program Coordinator for the Center of Environment and Population Health at Griffith University, Queensland, Australia. And then Professor Dr. Ignatius Sutaba, Executive Director of Asia Pacific Center for Eco-Hydrology, APSE, UNESCO. And then Dr. Febri Indra Budistiawan, Head of Public Health Department at the Medical Faculty of University of Muhammadiyah, Malang. And Dr. Sasmoyo Widito, Chair of the IDI, Ikatan Dokter Indonesia, branch of Malang, and also this official representative, Mrs. Valerina Yogi Buana Swastika Putri, MD FIHA. We are proudly privileged to have such a distinguished express join us today, and we eagerly await these insights, the knowledge that you will impart during the conference. I would also like to extend your heartfelt gratitude to LPPI, UMM, Lembaga Pengembangan Publikasi Ilmiah, Universitas Muhammadiyah Malang, and its chairperson, Dr. Fardini Sabila, MPD, for this unwavering support in making this event possible, along with the entire rectorate team. Allow me to acknowledge the present and express to gratitude to the esteemed leadership of UMM, Professor Dr. Fauzan MPD, the rector, and the Professor Dr. Samsul Arifin, MSc, Vice Rector 1, Academic and Development of Al-Islam Muhammadiyan, and then Professor Dr. Haji Nazaruddin Malik, SA, MSc, Vice Rector 2, General Affairs, Human Resources and Finance, and then Dr. Nur Subakti, STMT, Vice Rector 3, Student Affairs and Alumni, and Professor Dr. Siti Sunario, SH, MSc, MHUM, Vice Rector 4, Institutional Development, HR Development and Collaboration. Ladies and gentlemen, FKUMM, the Faculty of Medicine at University Muhammadiyah Malang, stand as one of the then faculties within the esteemed institution. Established in 2001, it has earned accreditation with the rating of the B. Over the years, FKUMM has proudly produced 1,819 doctors who are now making significant contribution both within Indonesia and beyond its border. Our annual conference, ICMedH, holds on special place in our academic calendar. Its purpose is to enrich knowledge, broaden horizons, deepen the understanding of medical science for our students, medical alumni, and fellow healthcare professionals. It strongly aligned with the FKUMM vision and mission of providing professional education and fostering national and international collaborations. As we embark on this symposium, I hope it proceeds seamlessly and successfully, offering of the platform for productive discussion, valuable insights, and fruitful collaboration. If any shortcomings arise during the execution, I ask for your kind understanding. In closing, I would like to express my gratitude once again for all of you, your presence and participation. Let us embark on this symposium with enthusiasm and optimism, and may it lead to innovative solutions to the global health challenges for face the post-academic in post-pandemic era. Thank you, and may this conference be resounding success. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Medi Setiawan, for the remarks. And now, ladies and gentlemen, I would like to invite Professor Syamsul Arifin, Vice Rector of Academic Affairs, University of Muhammadiyah Malang, for opening remarks via online Zoom meeting. Professor Syamsul, time is yours.
Yeah, thank you, Mrs. Ocha. I'm very missing my pictures, like still young, I think. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ocha, do you hear me, my voice?
Yes, your voice is so clear.
It's clear?
Yeah.
Okay, thank you. Very good morning to all the participants. Alhamdulillah, la hawla wa la quwwata illa billah. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadan abduhu wa rasuluhu nabiyya ba'da. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. Amin. Amma ba'du. The honorable, all of the invited speakers that already mentioned, both Pak Rubayat and also the Dean, Dr. Medi, like Professor Ali Gufron, and also Professor Ignatius Sutapa from UNESCO, and then our colleagues from BFIT, Australia, Dr. Feby. I'm so sorry I can't mention your name completely, but I still remember to you because we already met yesterday. And Professor Dr. Usni, we already met yesterday with him. And Professor Lee from Singapore. And the Honorable the Dean, Dr. Medi, and all of us team, and also all of the participants who joining the conference. Before I continue my opening remark, I'm so sorry for not being able to be with you physically, because I'm currently in Makassar to attend an event. Actually, the Dean, Dr. Medi, also invited with our friend to attend, but maybe due to Dr. Medi very busy, including his activity today, Dr. Medi could not attend together with me, with us, to attend the event that will be held tomorrow in Makassar, in one region in Makassar. So, on behalf of the Chancellor, Director, Professor Dr. Fauzan, I would like to express my appreciation to all of the parties who work well to organize the annual conference in the field of health and medicine, like the committee, and to all of the leaders in the Faculty of Medicine. And also I would like to give the appreciation to LPPI Lembaga Pengembangan Publikasi Ilmiah. I forgot the nomenclature in English. I'm so sorry, Bu Fatimi. And also the Secretary of LPPI, Mas Tommy. I hope that the conference will still be held in years or will continue to become an annual tradition, because the forum like this, according to me, provide many benefits here, including be able to disseminate our research funding, and develop the collaboration, the networking with various parties, with the professor in abroad, with any or some universities in abroad, like Griffith, Singapore, and so on. So, once again, on behalf of the Chancellor, we hope both medical faculty and the Faculty of Health can maintain this forum, not only this year, not only the third conference, but I hope in the next we will be held the fourth, the fifth, and the sixth, and so on. Of course, the leader, the Chancellor, would like to provide the support here regarding the implementation of the international conference, like ICMedH and other chapter that organized by LPPI. I think that's all. Thank you, and let's say basmalah together to start this conference. Bismillahirrahmanirrahim. Thank you, and the screen I back to Mbak Ocha. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Syamsul, for opening this conference.
Thank you.
Yes, enjoy your activities. You.
Okay, so my leaving, yeah. Okay, thank you. Yo.
Okay. Now, ladies and gentlemen, I would like to invite the Dean of Medical Faculty, accompanied by the head of committee, to come to the stage to beat the traditional gong as a symbol of the opening ceremony of this event. Please welcome Dr. Medi and also Dr. Rubayat. So please give a round of applause for the opening ceremony. Thank you very much, Dr. Medi and also Dr. Rubayat. Ladies and gentlemen, the beating of the gong signal the end of the opening ceremony. And so please, one more time, give a big round of applause for the opening ceremony of today's agenda. Thank you, Dr. Medi and also Dr. Rubayat. Please have a seat. So, ladies and gentlemen, may we continue to the main event. This is the first session of the presentation, and the presentation will be delivered by Professor Ali Gufron Mukti, PhD, CEO of BPJS Kesehatan, represented by Dr. Doni Hendrawan, Master of Public Health. I also would like to invite Mr. Febi Dwi Rahmadi, PhD, from School of Medicine and the Indonesian Program Coordinator for the Center for Environment and Population Health, Griffith University, Queensland, Australia. And the session will be guided by Dr. Yoyo Subagio. So please welcome Dr. Yoyo Subagio, Specialty of Neurosurgery. Time is yours. Once again, I would like to invite Dr. Doni Hendrawan and also Mr. Febri Dwi Rahmadi, PhD. Please come to the stage.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning and welcome to all participants. This day, my name is Yoyo Subagio as a moderator for the conference. And let me to feedback 2 years ago. This is the third conference and the first conference in 2021. This pandemic is so make us to challenge to make a conference. And we know all the several years ago, all in the world had a pandemic COVID-19, which made all sector is from the education, from the economic, from the healthy is stopped. Is how the solution and how the strategy to make it all better. Now through the third international conference on medical health science, we will be get some information from the great speaker. Maybe the first speaker from Mr. Doni, MD PhD from the BBJS, is represented from the CEO BBJS, and the time is yours now. Okay.
Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Dr. Medi Setiawan, SPPD Finasim, Dean of Faculty of Medicine, and the Honorable Dean Faculty of Health Science, Dr. Yoyo Bekti Prasetya, is right now is acting as a moderator, and all the presenter here today, speakers today, the Professor Dato Dr. Muhammad Husni Jamal, President of ONCA Asia Pacific Regions, and also Professor Gohli Gan, the professor from National University of Singapore, and then Dr. Febi Dwi Rahmadi from Griffith University, Queensland, Australia, and Professor Dr. Ignatius D.A., Executive Director from the Asia Pacific Center for Eco-Hydrology, UNESCO, and Dr. Febri Endra Budi Setiawan, Head of Public Health Department at the Medical Faculty of University from Malaysia, and all the ICMedH HD participants. First of all, I would like to extend a warm greeting from our President Director, Professor Dr. Oligo Frans, who currently today attending the UN Assembly in New York. So he sent his warm regard to all the participants here. And also, I would like to, in the next maybe, how many hours, how many time do I have? Oh, 30 minutes. The next 30 minutes, I would like to share our story about how BPJS Kesehatan as a national health insurance agency, how we adapt to the post-pandemic situation, and how we strive to reach the goals from which already stated in the law. It's not working. Okay. Lagi fun? Okay. This is an introduction slide. As you already know that the National Health Insurance Scheme is mandated by the law number 40 2004, and basically the model of financing that we choose is what we known is the social health insurance system, and it's basically based on the equity principles, and also the cross subsidy from a person who is not sick to the person who is sick, or the person who younger person to old person, something like that. And also the goals from this scheme is we want the government want us to reach what the state that we call it the universal coverage, which it stated in the law that in 2024 at least minimal 98% from all Indonesian citizens must be becoming an active member from the scheme. So right now we already reached around 92% from all the populations. We already covered 92%. So, but it's not an easy job. It's really a tough job, because I don't think that there is a country who already covered 100%. So it is still quite a hard job to do. And also what it means by the universal coverage is not only that everybody becomes the member, but it's also mentioned that everybody must have a comprehensive and timely access, and then everybody must have a qualified health services according to the law, and also everybody must know nobody bear an additional cost or financial burden when he have this health care that he need. And also as the body who organized all this scheme, we have quite a job to do, from registering members, and then we collect the contributions, and also we are managing all the data from our members, and also we pay for the claim submitted by hospital or any other health facility. Next. Yeah, next. And also, the question is how we can achieve that, because there are so many ways, as you know. Maybe we can take from the right side, or maybe we can take from the center, or maybe we can take from the left side. And as happening in our country, we also have a very big challenge. The first challenges that we're facing right now is the demographic transitions, where most, like right now, is around 50% from our member is a person who age over 60, sorry. And also we also facing what we call the epidemiological transitions, which most of the case that we cover right now is a chronic disease. And then we also must prepare for what we call it the emerging disease, like TB or Gustav, I don't know, malaria, something like that. So basically TB is one of the emerging diseases that we are facing right now. And also the new disease like COVID, or we don't know if I hope that there will be no other new disease happen. And also the climate change. Climate change also impact, like for example, right now the hot issue is the pollution around Jakarta, and is definitely bringing a lot more of our member into sick condition due of the pollution. And then a fraud and abuse that advancing also quite fast, something like that. So we have already thought about this for quite a long time, and we decided, and all the board of directors agree that I think that digital transformation is one of the good way to overcome all these challenges. And if we talk about digital transformation, it means that we must put IT as enablers, we must put IT as accelerators, and we must put IT as drivers. So this is the road that we are taking since maybe more than 10 years ago. Next slide. And we're also aware that in the next decades, the healthcare will be expand so quickly, so advanced, and it will feel fully fulfilled with a lot of new technology, like for example genomics, or AI, artificial intelligence, or healthcare will focus more on data analytics, and also the precision medicines, and also how we can get all the health indicators from the people from their device that they're wearing, what we in IT know as the Internet of Things, IoT, and also how we can conduct health promotion without tatap muka, we had without face-to-face meeting, something like that. So this is the challenge that we are all aware of. Something. Next slide. And we decided that we must optimize our digital ecosystem. As you know, as you can see from this slide, right now the number of our participants is 2,622,000,000 members. So it's currently around 92% from all Indonesian citizens. So it's quite a big numbers, but it also in resulting in very various data, various variables that we can analyze. And also right now we have already a partnership with more than 27 millions, more than 27 millions health facility, and also we have like nearly 1 million channels with all the financial sectors, banking or microcredit, something like that, to help us to collect the contribution from all the citizens. And also we have like interoperability scheme with the quite like 50 ministries right now. We really want to become what we call it the intelligent health insurers. What does it mean? It means that we will shifting to not only managing membership or managing paying claim, but we want to more advancing to ensure that all our members have a minimal risk to get sick. So we want to manage at least how they behave, how they interact every day, so it will reduce their chance to get sick, something like that. And we believe that the first thing that we must do is we have to increase our customer experience, and IT is one of the best solutions, I think, to increase the customer experience. And then we not only focus on the member, but we also focus or the patient, but we also focus to all the caregivers around the patients, because like I've been told you, more than 50% from our members is quite old. I mean, they have age more than 60, something like that. And right, if we want to advance digital as one of the solutions, we need all the caregivers who may be younger or who knows how to use digital things, digital tools to help them, because it will not work if we, for example, if we want to apply the online queuing system, but the person himself cannot use that because the lack of digital literacy, something like that. And we also think that system thinking and end-to-end planning and legal framework will be mandatory, and also IT will be part of the strategic and execution scheme. And we will focus at least at 4 things: how we can create a customer-centric personalization and engage omni-channels, and then how we leverage data, big data analytics to speed up decision making, and also how we can secure the data, both securing and preventing them to keeping their privacy, the data privacy, and then how we can build organization capability to adapt with the digital age. Next. And this is all the landscape that we working right now. So as you can see in the slides, in every point that there is a connection between patients and medical personnel, there will be digital intervention in that. For example, if the patient wants to go to hospital, he doesn't have to queuing. He just have to put his number or in the mobile apps, and then the mobile app will organizing his queuing or antrian apa? Queuing schedule, something like that. The apps will scheduling is app. I'm sorry because this is quite hard to presenting in English while the time is not so long. And then this is all the landscape, so you can all see. And for hospital claim, for example, we already use a paperless system. So there are no paper coming to our office right now. See, so you'll all submitted electronically, something like that. So, next slide, please. And then so we will see what we have done, what we have achieved in this last decades. Next. So first of all, we already conduct digitalizations in all of our area. For example, we have what we call health facility information system, where the applications contain all the vital information about the health system. For example, how many doctors they have, what is the scheduling time, or what is the equipment, the medical equipment that already have by the hospital, something like that. And also we have what we call virtual claim systems, where the hospital, all the health facility can submit the claims without using paper anymore. And then we have what we call primary care. Primary care is basically an applications using by the primary care. And right now we expand the P-Care is not only to submit the claim or just to record activity, but we want them to, we want to increase the function of primary care as the medical record, electronic medical record, something like that. And also we have what we call it pharmacy online. So the pharmacist can, for example, know how many drugs it will be needed from the health facility that he has, they have partnership with, and also what we call it the queuing system, the electronic queuing system. Next. And then this also we have a customer-centric solution, for example. So in every hospital right now, we have a dashboard, a descriptive dashboard that will show all the patient, how many beds are existing or how many beds have been taken, and also how many operation is conducted right now, and how many operating room is available right now. And also we also provide our member with teleconsultations using their mobile apps. And also we have using biometrics sensing indicators to validate our members when they entering the health facility. And in the next year, we will start using the face recognitions, and also another biometric sensors, for example, like the retina, eye identification, something like that. Next. And then we also establish an interoperation system with the related entities, for example, with Minister of Health. So we have integrated our system with the Minister of Health in tackling COVID-19. So basically our system is using by Minister of Health to collect the data, and then we share the data with the Minister of Health. And also in hospital, we also have connected our virtual claim with the e-claim from the Minister of Health, and also with another entities, for example, with the Jasara Harja, with Taspen, and any other entities. Next. And this is the super apps that we are still developing right now to become the only digital office, I think, for our members. So they don't have to go to the office anymore. So they can do whatever they want to fulfill what they need just through their cellular phone, something like that. And this is the super apps that we still developing right now. Okay, next. And then this is we also using the super apps, the mobile JKN, to deliver or to conduct health promotion and prevention. For example, we blast the health promotion message to the page to our members. So something like that. Okay, and which also they can conduct self-screening through the mobile apps. Okay, next. And then we also establish teleconsultation through the mobile apps also, and many members have already using this. Next. And then the latest development that we make is what we call the iCare. The iCare is basically that all health facility can access the history, the medical history from the patient whenever or wherever the patient entering or goes to the hospital or primary care clinics. The primary care clinics or hospital can see the history of the medication that already taken by the patients. So it will ensuring the continuing medication from the patient. Next. And then this is the latest development that we give to the hospital. So we give them what we call the analytic dashboard for hospitals, so they can see the status of their claim, the situation from acquiring system in the hospital, and also to know how, for example, what is or how much is the hospital bed rate, for example, something like that. Next. And this is the e-health medical records, which can be seen by the member through their mobile apps, so they can see their medication history over there. So next. And it is also developing artificial intelligence. We have developed a lot of artificial intelligence, and the latest artificial intelligence that we develop is artificial intelligence that can detect the TB patient which are taking medication, something like that. So it will help to substitute cadre who always have to see the patient taking medication. But right now we started to develop AI, for example. But we have developed a lot of AI, for example, AI to mitigate fraud or to detecting fraud claim in claim, or in Jampersal SIM, which launched by the Minister of Health. We use AI to verify all the claims. So we are not using persons to verify all the claims anymore. And this is all the ministry that already have interoperability with us. So basically right now we are supporting, for example, coordinating Ministry of Welfare. So we support them with a lot of data. So the data will fulfill all their war rooms, and also, for example, the Minister of Law and Minister of Finance. So we have a lot of interoperability with all the ministers. Next. And also we give local governments what we call a local government dashboard, so they can see what is the progress of the national insurance scheme in their region. And also we give them a lot of data, so they can conduct a surveillance system. For example, we give them data about a chronic disease like hypertension, diabetes, or data for infection disease. For example, like respiratory disease, something like that. So they can basically design a health policy from all this data. Next. And we also provide data samples that can be used by researchers or university. And right now the number of data samples is around 47 million data. And right now my team is currently working to updating the data, and we hope that this year we can release nearly 60 million data, and the data can be used to conduct research or creating policy, something like that. And the next year we will also develop what we call a synthetic data. So if anybody wants to develop AI, they can use our synthetic data to create AI. Still, without harming the privacy of the data. So something like that. Next. And then the last part is what is the result and the key takeaways from all of this. The result is that, as you can see, our customer satisfaction index is quite good. In 2020, it's around like 87.6, and also for the health facility satisfaction index is around 87.3, and in organization image is quite good also. It's around 86.23. So it's also challenging how to maintain this or improve this. Next. And also, as we can see, since the scheme is established, the number of out-of-pocket payment from all the from in Indonesia is decreasing quite good. Yeah. For example, in 2030, the out-of-pocket is around 48%, but right now it's only 25.1%, and it keeps reducing. For example. Next, and also a lot of institutions maybe appreciate what we have achieved. So yeah. So next, but this is the very important key takeaways. Using digital health is not only connected, but before that we have to do a lot of things. Like for example, we have to have enough data storage and management, because if we try to connect to others, a lot of data will flow into our systems. So it means that we have to have a lot of data storage. Because if we put it in the clouds or something, it will be quite, if we're not taking it seriously, it will be quite fatal, because yeah, it can easily taken by others. The second is we have to have data sharing protocols, and it's very important because a law already exists, the law number 27, 2020 about the data privacy. And also we have to improve the process, because what we are talking right now is about digital transformation. Digital transformation is not only making something analog to digital, but also we have to improve the business process and giving the new value. So this is the very important things. And we have to ensure that all the data as a product of technology is have a very good quality, because it will useless if all the data is not giving the right insight. And we also have to increase the digital literacy and digital cultures, and also we have to have a very good data protections or protection systems, because as the institutions who have data, a very big data, we have to at least conduct two very important things. First, we have to protect them, and second, we have to keep the privacy of the data. So this is the very important things that we have to do. Okay, next. And the key takeaways is optimizing digital health is a must right now, because yeah, it's a must. It's unavoidable, and it is a very good way to overcome the challenge and to ensure the sustainability of the scheme. But if we want to optimize digital health, we have to make sure that we have a very good compliance with data protection and data privacy, because it is a basic human rights. I mean, we cannot just share all the data to everybody, but we have to make sure that we compliance to the data privacy rules. And also, digital health will impact will produce a good result if we strengthen the three aspect tools, people first, and then the process and the tools also. And we have to do it step by step, and also supporting by the clear regulations. And then the last key takeaways that we must, from what we have experienced, is that literacy, digital literacy is a very essential and very important to optimize digital health. I think it's all from us. I'm sorry if my presentation is not very good, because yeah, I have to admit this is quite hard to speak in English in very short times. But I hope that everybody here can at least take what we have experienced as the reference to optimize the digital health application in Indonesia. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Doni Hendrawan. The nice presentation and the nice information. I know in this room, all of the participants, we use or be a member of BPJS. It's true? Yes. Yeah, it's the member of BPJS because the BPJS so helpfully for the our healthcare, maybe in the hospital, in the clinic, and the others. And I know the complexity to make a system, the BPJS, but we just know to use the BPJS simplicity to go to the hospital to register by online. It is so helpful, but it's the so complexity by data by system is the so complexity. Then just information, the Dr. Doni is the deputy of data. Yes, it is so important people in BPJS. So applause for the Dr. Doni. And I am sure for the participant have some question for the BPJS. Yeah, but it's keep. And we continue the next speakers. Is so interesting. Mr. Febi from the Griffith University. He so expert in the family medicine and so the disaster. But for this time, he will present about the impact of the COVID-19 and by the health and health system and how the solution, and we will be hearing this presentation from the Mr. Febi. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. It's a pleasure for me to be here. It's an honor for me to be here, standing in front of very important people in this classroom. Why I say very important person? Because we want to learn about how we can do better in the future. So your role is very important. And I need to also acknowledge the professionalisms of UMM in organizing this conference. Your hospitality is so amazing. So we've been very much welcome in Malang, in UMM. And this is actually also my first international conference that I attend offline. Because normally we do online presentations, but this is the first time for me to be overseas and doing conference. So let me just... All right. So first of all, also I'd like to comment to what Pak Doni or Dr. Doni has already mentioned. So I think BPJS is one step ahead from what we have in Australia. In Australia we do have Medicare. Australian population is only about 27 million. And Indonesian population is about 280 million, so more than 10 times of Australian populations. So data management is so complex, even though like in Australia we have smaller populations in number, but last year we just got hacked as well. One of our telephone provider in Australia and also private health insurance got hacked. So they stole our data, but then the government replaced all the ID card of those who've been hacked. So that is the responsibility of the government. So they have to pay everything. So we don't have to pay anything. But because data is very important, right? So Pak Doni's role is very important. So Pak Doni knows of all of our data. So thank you, Pak Doni, for your great work. So what I'd like to talk today in relation to Pak Doni has already delivered his presentation. So I'd like to look at from a bit more global perspective about the COVID implications on health system and services and what need to be done differently. So that is actually important, right? So I also would like to, Prof. Goh and Prof. Husni, so sorry if I speak before you. So, but it is actually very important for us to know what is actually the next process. For me to be here, standing in front of you, you have to fly from Brisbane to Sydney, Sydney, Jakarta, Jakarta, Malang. So I don't know how much carbon footprint I made from Brisbane to Malang. So I want to make sure that after we attend this conference, we have to make something different. Yeah, so this is important because otherwise I feel bad because I've made a lot of carbon footprint, but without any positive contribution. So, let me share some of my presentation here. As we all know, COVID-19 crisis has revealed structural weaknesses in health system. Oh, sorry. Yeah. So as you can see in this picture, so this picture tells 1,000 words or million words, right? So I took this picture as the first slide of my presentation because as you can see, healthcare, health system, we are in the front line, okay? And COVID-19, in some report, they don't actually weaken the system, but they actually expose the system that is weak, right? So COVID-19, to some extent, we can actually learn from COVID-19 what aspect within our system that need to be strengthened. Okay, so and this is a global pandemic. So every country, all country around the globe, they experience the complexity of dealing with COVID-19. Even the superpower country like the United States also experience even more than what we experience here in Australia or what we experience in Australia. Okay, so it's a very complex situation. It's a new disease. Although firstly we thought it's similar to influenza, however, in reality it's actually not the same with influenza. So COVID-19 pandemic puts health system under pressure. Okay, and in particularly if we already being pressured by a lot of other things, okay, because they are in the context of risks, because I'm coming from emergency risks management concept, so there are actually two different types of risks. The first one is extensive risks and intensive risks. So extensive risks is like a pandemic that we are not currently facing. So what last year or the last 3 years we faced. So that is intensive risks. Okay, risks that happen not so often, but the impact is so big, so huge. But there is also what we call by extensive risks. So that is actually the existing risk that we have. So the impact is not so high. However, the frequency of the likelihood is so high. Okay, so the impact is low, but the likelihood is so high. So this is what we call by chronic stresses. So we have environmental issues, we have economic issues, social issues. Okay, I'm not talking about Indonesia, I'm talking about the globe, right? Cultural issues as well, which might lead to what we call by predisposing conditions. which will then interact with the acute events. So it could be any type of disaster and also pandemic as well. I always forget that I'm actually using the two different two different screens. I have my laptop and also the other one here. So this is what I call by chronic stresses. So analysis of the pandemic's epidemiological and political context reveals a perfect storm, okay, of rising chronic disease, social inequalities, cascading public health failures, fueling the pandemic. So this is very important, right? So to understand that this disease, not only that this is a new disease, but this is actually a political, I would say, rich as well. Yeah, so like what happened in the United States, like what happened in Victoria in Australia. So in Australia we have 7 states, 2 territories. So Victoria is, in terms of COVID-19 management response, is one of the, because they're more complex, they have more populations instead of Queensland. So even the premier, he stepped down because of COVID, because people want him to step down. So it's a very political, rich situation as well. However, in Queensland, so I must say Queensland was in Australian context, we are quite leading in terms of COVID-19 management. So it was so in terms of the fatality case, and also the case also much less compared to New South Wales and Victoria. Okay, so it is also important to understand, because learning from history is an important step for us to be able, to face future. Okay, even there is a wise man say that donkey will not fall to the same hole for the second time, right? So donkey. So we are human beings, so we have to be able to be better than donkey, of course, right? Because we learn better from our history. However, from the 1918 Spanish flu, we also have SARS, we have avian influenza. It seems that we always repeat the same mistake. So I still remember after SARS or after H5N1, there is a lot of discussion about what is the next, post-pandemic, what need to be done. And this is also the same thing like what we are currently doing. So next pandemic, what need to be done? Okay, so learning from history, if you look at this, so I highlighted the keywords. Okay, resources to prevent COVID-19 were limited or not available, because COVID-19 considered as a new disease, so there was no resources in relation to COVID-19. So a lot of countries, they try new things in terms of the either pharmaceutical and non-pharmaceutical measures, because it's quite new. Limited search capacity and low testing ability. Even in a country like Australia or America, this is also something that is also quite concerning. The pandemic may also have resulted in some people being spared unnecessary or inappropriate care. So this is happening as well. People consume a lot of medications without consultations with their general practitioners, because they think this might cure the disease. Okay, even not to mention as well, we have misinformations of hoax. People consume a lot of medications, traditional medications that might also impact their health, status as well. There was also a story in Iran, so where they consume 70% alcohol as part of their efforts to cure the disease, but a lot of people they had to die because of consuming that 70% alcohol. So all these are what we call by inappropriate care, and that happened during COVID-19. Missed appointment for chronic care services like cancer, like in Australia. We have high case of skin cancer, so missed appointment for this type of disease as well. Elective surgery had been postponed because of COVID-19, because they deter all resources focused on COVID-19 disease. Okay, health professionals perceive stigma, safety concern, because health professionals like all of you who are in this ballroom working in the hospital, and hospital have become the front line, okay, is very much exposed by the virus. I don't know how many heroes, health professionals that had to die because of COVID-19. So those are our heroes, unsung heroes, right? And many other things as well. And in the context of maternal and child health interventions have been delayed, especially in sub-Saharan African. A lot of mother and children, they died not because of COVID-19, but because of they missed a lot of services. So this, I took a paper here. This is just to provide, like a picture. This is a systematic review from 81 studies coming from 23 countries, multinationals. So unfortunately, there is no single studies in Indonesia. Okay, about maybe mainly from United States, UK, Japan. We also have one from Malaysia as well, included in this survey, systematic review. And if you look at this one, 37.2% utilization has been reduced because of COVID-19. Okay, so a massive global reduction in healthcare utilization summarized in this review makes a compelling case for prioritizing efforts that address the unmet needs of those with non-COVID-19 illness. Okay, so this 37.2, so I'm not going to read in detail. So those people, because they avoid healthcare, not because they don't need, just because they're afraid of COVID-19. So that will also lead to another problem. Another study that I also would like to share with this conference as well, the impact of COVID-19 with non-communicable disease patients and health system. And I think this is also important as well. Maybe in the context of Malang, you can conduct the same study as well, to see what can we learn from COVID-19, so that in the future we have a better situations to deal with future pandemic. Like this one here. So this is a COVID-19 specific factors, and we also have direct healthcare system factors, indirect health system factors. If you look at in the middle here, we have frontline healthcare worker burnout and mental health impacts. So this impact everybody in the healthcare system. Okay, so not to mention as well, we have a lot of other things that is non-related to COVID-19, but then interact with COVID-19 situations. And it is also important to acknowledge this as well. What do you see here in this picture? Waste, right? So according to the data that I have, about 87,000 tons, that just within March 2000, November 2021, 87,000 tons of plastic waste, plastic related, this is a medical waste, so it's a biohazard as well. Not to mention it is a plastic, and it is also a biohazard. And only and according to WHO report, about 30% healthcare globally, they have no capacity to deal with plastic waste like this. Okay, and 60% of this 30% are located in low, middle income countries. Okay, there is also, I think, report, but I couldn't find the report. So this is something that we as a health professional, we also need to understand how Indonesian hospital, or maybe in Malang or in East Java, dealing with plastic waste. Because we as a people who work in the healthcare professionals, we also have to think about the environment, right? So because mainly they go to incinerator, but incinerator will then, that will cause emissions, and those emissions, like especially carbon monoxide, will then potentially can cause cancer and then people go to hospital again. But then hospital then produce the agent that might harm the human being. So this is something that we also have to think about as well. So COVID-19 also intersect with the triple billion. This is a very ambitious goal of the WHO, which is a 1 billion universal health coverage. And I think BPJS is doing really good here to make sure that hopefully the WHO can achieve, the goal before 2030. So this is actually very important, and 1 billion more people better protected from health emergency. As we all know, with climate change, anthropogenic climate change, increasing climate-related disaster, not only in terms of frequency but also the intensity, and 1 billion more people enjoying better health and well-being. So triple billion is very ambitious, and COVID-19 has delayed this process. Okay, not to mention as well with SDG process has been delayed as well because of COVID-19, from educations, from health equity, gender issues, everything has become more complex. So hopefully we can actually do better in the future. So we did a study. So this is one of our master students at Griffith University. We did study about alcohol consumptions during COVID-19 pandemic. So it has gone, it increased quite significantly. The study was done in Gold Coast. So Gold Coast, have you been to Gold Coast? Gold Coast is like Bali of Australia. It's about 1 hour from my, well actually I'm based in Gold Coast. So then COVID-19, so we did study, and this is from adolescents, right? Adolescents, and they increased alcohol consumptions and also tobacco consumptions as well. So it's quite significant. So that can lead to another problem, right? So then the question is, because we need to then step forward and think, what do I need to do ahead? Okay, we have done. Okay, we survived. All of us here survived. My auntie did not survive. My auntie passed away, and I also heard one of our parents also passed away because of COVID-19, right? So I think a lot of beloved families, members, right, passed away. So we are survivors in this classroom, or those people who join online. We're still alive, so we have to do something. The question is, which health sector investment can reinforce resilience for future health emergencies? Okay, and this is a question not for me, but it's actually for all of us here. Okay, and just quickly, because it is also important for us to understand that risks is systemic and crises are cascading. Okay, it is, of course, from disaster management perspective, risks equal to hazard multiplied by exposure and vulnerability. Okay, so that is the equation of disaster risks. However, in the context of big city like Jakarta, Malang is also bigger and bigger. Risks is more complex than that. Okay, so if you look at this one here, hazard. This is a hazard, the virus, earthquake, cyclone, whatever it is, right? We have exposure, vulnerability, and hazard. However, in the context of urban settings, that become more complex. Interconnecting all of our knowledge is very complex. So, especially as I said before, in Indonesia we have 218 million people, so it's not as easy as we thought. So it is important to have system for resilience. Indonesia will move the capital closer to Malaysia, to Kalimantan. So although Jakarta is still the biggest city in Indonesia, so it's very complex because city is not only healthcare. So healthcare is one of the most important, of course, but we have transportations, we have telecommunications, we have energy. So all these are actually interrelated. So there was a question yesterday during our public lecture. One of the students asked about what needs to be done by medical professionals in the future. So one of the most important things, and I think it was also mentioned in Pak Doni's presentations, interoperability. So working together like the whole of government or the whole of society, we need to work together. And WHO has already released, this is the Health System Resilience Framework. Okay, so it's very much depending on us. So this is the guidelines. Now, what can we do in Indonesian context? But if you look at the middle, it's a community engagement. Community engagement is very important, right? And they play a very important role in terms of governance, financing. So PPP has been very important as well. And I think from the global perspective as well, we have more philanthropy organizations provided funding. So otherwise, government will not be able to solve it by themselves. Even like in Australia, Donny, so we have Medicare, but if we only have Medicare without private insurance, and we have to pay Medicare levy about $2,500 per year if you don't have private insurance. So we have to pay tax more. So they actually force us to have private insurance. Okay, so that will basically to reduce the burden of the healthcare costs. So although they have the money, but they just want to keep the money. Okay, so no need to wait for another pandemic to change. So we need to change now. Okay, and it is also important. I saw the banner in front of our in front of our hotel. It says post COVID-19, but actually it has to be changed into prior to future pandemic. So it's actually a mindset. So is it a post-pandemic or prior to future pandemic? Because we know things will happen in the future. I don't know whether you have read the World Economic Forum report, Global Risks Report 2023. In the next 2 and 10 years, there will be another potential things happen that might come through due to environmental degradations. So we don't know, because spillover from animal disease to human disease, it has happened. Re-emerging, new emerging disease, 70% of new emerging disease are disease from the animals, okay? So which is environmental. So it is important for us to change our mindset. So these are the characteristics. So I'm not going to read this in detail, but we have aware, agility is very important. So we need to be adaptable, absorptive, okay? Absorptive like a boxer. Like boxer, you have to be able to, if your opponent punch you, right, you have to be able to accept that punch, and then adaptive. Adaptive means you have to make movement and punch back. You have to win the competitions. So by being transformative, integrate, multisectoral, and etc. So what is actually new as well? I know time is very limited. Maybe another 3 more minutes, but it's okay. 10 minutes, okay, then that's okay. Because I always feel worried if moderator look at me. I thought the time is limited. Okay. Okay, so what is actually new? So WHO launched something new. I believe everyone know about IHR, International Health Regulations, 2005. However, it's not really legally binding. So it's like tiger without teeth. So nothing, you know, a country, if they don't report, there is no consequences. And that is actually the problem. WHO cannot give sanction, right, to a country. So that's why they want to have an accord. They want to have a new initiative to improve pandemic preparedness. Okay? They have continued negotiations on global agreement on pandemic prevention, preparedness, and response. So they need to have a better system, better collaborations. This is a global health. This is not just... That's why we have moved from international health approach. International health approach is where developed countries help developing countries. But global health is equal, everybody equal. Okay, now a disease in one particular country in Africa, named Zambia, so with the current transportation system, that disease can reach our backyard within 3 days, that disease. Okay, in a very small village in Zambia, I'm just making it up, okay? But that is actually showing the world is getting smaller and smaller. Australia is currently putting a lot of money. I think that's why they cut a lot of our money. They commit 90.9 million to establish Australian CDC. Australia doesn't have CDC yet, like Chinese CDC, American CDC, or US CDC. They want to develop a new system. Australia has a pandemic intelligence, they call it Pandemic Intelligence Committee. I forgot the name of it, so it's a federal government. They have chief health officer at the federal levels, they have chief health officer at the state level. So the system is a bit different with what we have in Indonesia. Australia is a federal country, so different states might have different system. So they want to have a unified system, so they want to have Australia CDC. So currently a lot of research being implemented in terms of the what will be the best system that can be done. So this is also one of the new things in Australia in relation to COVID-19, because you don't know what will happen in the future, so they want to have a better mechanisms in Australia, but it costs a lot of money, 19.9 million, to support the establishment of this new agency. So, and this new accord, they also have what they call by preparedness resiliency for emerging threat. Okay, so this one, although it's not really nice in Indonesian. Pret is like pret. It's a pret. It's they call it preparedness and resilience for emergency threat initiative. Okay, but pret in French means rapid, so fast. Okay, but in Indonesia maybe it doesn't. It's the connotation is negative, pret, right? But it's actually very important to have this new initiative, preparedness and resilience for emergency threat. Okay, and this is also a thing that is happening as well. Health promotion as the center within global health mechanisms. I remember yesterday Prof. Goh mentioned about ABCD. The disease prevention, health promotion. So now health promotion become the first one, A, not the D one. So become the center for the everything, because health preventions, it's like the upstream. And I also like Dr. Donnie's presentation about the mountain. So we also use that kind of, to illustrate. So on the top of the mountain, that is what we call the upstream level, the macro level of health, and the downstream is the health outcomes. So that is the health treatment, hospital, important, but then it's actually coming from the upstream. But upstream, the more you go to the top, the more politic the solutions. The more you go to the bottom level, the more technical, laboratory, vaccine. But the money, the policy is actually at the top. So it's very important to touch people. So Pak Doni's role is very important. So this is what we call by the health promotions at the center of global health. So, and then you can have a look at this later. And there's actually a new, it's not really new, so it's 2019, just before COVID-19. It's a Y-Ora concept. So Y-Ora is not from Australia, but it's from Maori. Maori is an indigenous population in New Zealand. Okay, sorry. This one. So it's a Rotorua statement. Rotorua statement. Rotorua is one of the city in New Zealand. It's actually promoting planetary health and sustainable development for whole. Okay, so basically we are talking about one health approach, planetary approach, thinking about our future generations. Just look at the first one. Ensure health equity throughout the life course within and among countries and within and across generations. So not only about our generations. So what's the point of, okay, let's save our life by producing a lot of plastic waste? We are not thinking about our future generations, because they have to pay the outcome. Okay, because that will then also reduce the environmental capacity to deal with the problem. So we have to think about solution that is more sustainable. And so this is a pressure relief model. So I've been using this in many of my presentations, because this is very important for us to understand what is actually the root causes, the pressure, unsafe conditions, and the capacity. So we have a lot of efforts in terms of capacity, testing capacity, contact tracing, public health emergency, health preparedness. We increase ICU capacity, we increase bed capacity, but those are maximized capacity. What about the unsafe conditions? What about awareness? What about air pollutions that is happening, because that will interact with the disease? What about the pressure, media coverage, social capital? Policy synchronizations is also another thing that is very important. And last but not least is the root influence, which is political commitment, okay? Effective leadership is very important. Effective public communication is also important. So dealing with COVID-19, it is important for us to address all of these things without waiting for another pandemic to come. Those are the hazard, the agent, the pathogen, the virus. So we don't have to wait for another disease to come. Okay, so just before I end my presentation, so we have this as well. This is ongoing at the moment, the current integration of health and disaster risk reductions. Just to give you some updates as well. And also, this is a publication that we published a while ago. And this is about policy synchronizations, because health, emergency, disaster risk management, WHO has published a guideline, and we would like to see to what extent Indonesian policy has already been following the guidelines and what are the gaps. It is important for us to understand what is the gap. And this is another publication that we did in relation to COVID-19. So how can public be better protected against COVID-19? This was published sometimes in 2020, so early phase of COVID-19. Basically, it's more about policy synchronizations and ability to deal with people in rural areas. Indonesia must do more to tackle coronavirus crisis. So there was a discussions about at the time whether they need to do lockdown or not, but then we discussed this and we provide this paper, and this was published by the Australian National University. Basically, we need to be a bit more agile, in relation to COVID-19. Public health resilience, I'm not going to read this in detail, but you can have this in your presentations and in your PDF format as well. So these are the 10 characteristics of us to be more resilient in the future. And this is Making City Resilience by 2030. It's a movement. So you can also go to their website and see how Malang is resilient. To what extent Malang is resilient to pandemic, to what extent Malang is resilient to climate-related disasters. So all, they have this indicator. You can have a look at it yourself. The U-shaped approach is very important. This is a new type of resilience system. This is a workshop that I attended sometimes in 2021 by United Nations Disaster Reductions. It's a top-down. Top-down means from government to community, provide information, accountability, side to side, community to community, support each other, and community to government. So community can provide response, feedback to the government. So that's important, the U-shape. So it's not only top-down, it's not only bottom-up, but side-to-side is also important. So it's a U-shaped resilience. People-centered resilience building, this is also another publications that we made as well in relation to all solutions is important, but the center has to be human being. Take-home message, so health is more than healthcare, and the whole of government approach to health and well-being is needed to create health system resilience. So it is important for us to work in collaboration. So from Griffith University, I look forward to have a collaboration with UMM, with Prof. Husni, with Prof. Go, because we need to be able to have a better system for future pandemic. Thank you so much for your attention. So I look forward for discussion. Thank you.
Thank you very much. The great presentation from Mr. Febi. And I think it's the health system in Indonesia or in the world is must be to covered by the many sector like as insurance in the BPJS and the movement in the Medicare in the Australia. Yeah, it's so supported to make a health system, the good health system in the world. Now, Mr. Feby say to me, if you give me the more time to presentation, more than 13, I give you a gift from Australia. Is true? No, maybe, and I say to use the door prize to the participant. Oh, why do the door prize? I don't know. Maybe the participant have any question and will be the answer the speaker in here. Now the time is the Q&A. Yeah, maybe from the participants have some question or suggestion. Okay.
Okay, thank you so much. Assalamualaikum warahmatullahi wabarakatuh. Good morning, and let me introduce myself. My name is Dr. Ronald. I'm coming from the Surabaya. I would like to express my amusement. Tes, okay. Okay, I'll cut to the chase. Question for the Mr. Doni Hendrawan. I've read an article in CNBC Indonesia, April 4th, 2023. That actually the director, Prof. Ali Gufron, said that the objective for the BPJS Kesehatan in 2023 is to achieve 91% coverage from total population of Indonesia, and it is an improvement and achievement that, as you said, 262 something million already the participant. It's amazing. Applause for that. Yeah. But there is one problem. I also read at the Occasion article. Sorry for the it's just like popular social media news that Indonesia is the leading, world leading, 70.5% smoking. Yeah, smoking. So, and as we know, the cigarette advertisement seems more interesting than the BPJS Kesehatan advertisement. So people, especially the smoker, would be willing to spend more money to buy cigarettes than to pay the BPJS Kesehatan. What is your take on that particular issue? And one question for Speaker Feby Dwi Ramadi. Very interesting presentation. I just want to ask, how does climate change contribute to more diseases? And what can we learn from the pre-pandemic, yeah, not post-COVID era, but pre-pandemic, to protect the public health? As an interesting note, the carbon emission was reduced, and ozone layers were healed more during the pandemic. And what can we say? There are more lockdowns, so the plane is less before compared to before and after the COVID pandemic. What's your take on that? Those are my questions. Thank you so much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Yeah. Thank you for the question. Maybe one question again. Okay. One question again.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi.
Thank you for the change to I ask for Dr. Febi Dwi Rahmadi. I asked about how we can deal or prepare for the future if there is we face to the pandemic again, especially like our country Indonesia. And as you know, there is many country like United States had a good health system, but they are reporting high mortality and morbidity too. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for the question. Maybe directly to answer the first question from Dr. Ronald. Yeah. Maybe from.
Yeah, thank you for the question, Dr. Ronald. I mean, is Indonesian term is a difficult, easy question. I mean, it's easily to answer, but exactly it's not an easy question to answer. What BPJS standing about this issue? I mean, first of all, we really supported the tobacco cessation. We really support that because, as we know, there's a lot of evidence that proves that, show us that tobacco creates a lot of diseases, and it's clearly consume a lot of resources, financial resources that we are managing right now. For example, the top 10 diseases right now that we are financing is heart disease and stroke disease, diseases like that. But on the other side, BPJS is formed to ensure the basic right of citizens, which means that everybody must have access to healthcare without any other obstacles, or we cannot forbidden somebody even though they have a lot of health risks if they want to become the members, because we are a social health insurance, which means that we must ensuring that everybody can have access of healthcare whenever they need it. But instead of that, we supported government, we support the movement to reduce tobacco by giving, for example, by giving data to Minister of Health to create a campaign, for examples. So, or we can conduct. Right, we have already thinking about maybe we can create some kind of benefits, smoking cessation benefits, something like that. And we also provide health promotion through poster, through pamphlet, something like that, to aware our member that smoking is not very good for your health, something like that. This is at least we can do, but we still right now is thinking hard how to improve our role in this, because actually we are a public health insurance, I think, because we really connected to the public health and really supported by public health. If the public health is good, it will impact us in a good way. But if the public health is weak, it will give us a disaster, I think, because there's a lot of diseases that we have to finance. So I think this is my question. Thank you very much.
Thank you, Dr. Ronald. Dr. Ronald is a very good singer with a very beautiful voice as well. So about tobacco, is actually I also would like to provide a little bit more comment on that as well, because Australia used to also a country that we have, I think in 2 decades ago, so about 25 years ago, about 39% adult smokers. But now we can, into 2021, I think about 12%. So it's a huge reduction because they increased the price. So $45 for one pack. Jadi 450.000 untuk satu pack. so that if Australia, Indonesian government would like to, maybe, but this is not a good time. Pill press, increasing tax is not a good timing because pill press is next year, because that is not it's not a good. There will be a political impact on that as well. Okay, so the question was about climate change and disease transmission or disease pattern. As we know, epidemiological triad, we have host, agent, environment. So climate change can alter the environment, and we must say anthropogenic climate change. So anthropogenic means it's a human cause climate change. So human cause, we human, so we play a very major role in terms of climate change. So they can alter the environmental system. So be it in terms of humidity, the rainfall. There has been a lot of evidence also showing climate change or changes in terms of humidity that might increase the prevalence of dengue fever, for instance, because of the mosquito itself. They can distribute. They can, multiply quite significantly faster than before. So, and also can alter the host as well, human being, because due to increase of heat wave, cold spell, so that might also reduce the immunity of the human being as well, the host. So, with the weak host and environment that might lead to disease, so that is where disease exists, or illness exists. So a lot of discussion about that, Dr. Ronald. So, and in terms of how can we stop climate change, because I spoke to one of the experts from UNFCCC who is based in Canberra. Even though everybody in the world stopped doing anything, okay, turn off TV, turn off AC, no car, no motorcycle. Everybody, every single person in the world, the climate is still changing, because it's like a big train, like coal train. So even it takes a lot of, when they press the brake, it will still moving, right? So press the brake, still moving. Maybe for another 15-20 years, the climate is still changing, because it's a very big energy. So you cannot stop climate change, basically. What you can do is actually to reduce the speed, hopefully. Okay? So that's Dr. Ronald. And the question was about, I think, so it's about how can we have a better preparedness system in the future, prior to another pandemic in the future. And you also mentioned about the case in United States. United States in 2019 has been nominated as the country that has the best global health security, in 2019. But then not long after that, we have COVID-19. And the biggest cases, the biggest fatality case also happened in the United States. And a lot of paper has been published about that as well. And one of the factor is political commitment and negligence. So negligence is one of the most important aspect. Social capital, social cohesion. I don't know whether you have heard about this news. There's a firestorm in Hawaii. So, and the early warning went silent. So that is, Hawaii is still America, but the early warning system was broken. Can you imagine like that? And kills a lot of people as well. So mostly those are related to negligence, political leadership. So Indonesia need to learn from that case as well. So leadership, commitment, political commitment is very important, and the U-shaped resilience. So working together with the government and society need to work together. I think Muhammadiyah play a very important role. Not only they have university, they have hospital, they have MDMC as well, they have ICMedH. So all these are important organizations that can help Indonesian government in the case of emergency. Thank you.
Thank you very much, Dr. Doni and Mr. Baby, for the great answer. And because the limitation of the session, we have to end the session. And the closing statement from the two speakers, I think, is if we want to good health system, we must to have a great power. The great power is not only from the personal, but with the global health system. We must to push the energy to make a great health system. And thank you very much from the nice presenting from the Dr. Doni and Mr. Febi. And we hope the pandemic is over. It's no next pandemic. It's the offer in this year. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Doni and also Mr. Febri. You can go back to the round table. Okay, shall we continue to the next discussion? Ladies and gentlemen, the second presentation will be delivered by Professor Dato Dr. Muhammad Husni Jamal, DNBS, President of World Organization of National Colleges, Academies and Academic Association of General Practitioners or Family Physicians for Asia Pacific region. And the second speaker of the session is Professor Guhli Gan from Division of Family Medicine, Yong Yulin School of Medicine, National University, Singapore. And the session, of course, will be guided by Dr. Yoyo Subagio again. So, Dr. Yoyo Subagio, the floor is yours.
Thank you very much. I hope the participant is not boring with my face in here. So, okay, the next session will be the speakers from the Malaysia and also from the Singapore. And for the first speaker is Professor Datuk Muhammad Husni. He is World Organization of President WONCA, World of Organization of National College Academic and Academic Association of General Practitioner Family Physician Asia Pacific region. And he will be presented about the global collaboration and cooperation in health research and practice. And time is yours, Prof. Husni. Okay.
Bismillahirrahmanirrahim. Apologies once again, my voice isn't fully recovered. the Dean, Faculty of Medicine, Dr. Medisa Tiawan, distinguished speakers, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. I'm glad to be back in Malang again after my first visit in 1981 as a young medical graduate from University of Malaya. I took a long holiday over the whole of Java, and now I'm back as somebody who's going to retire from the medical school. Now my topic today is on global collaboration and cooperation in health research and practice. Now I will be speaking to you in the capacity of the WONCA president, as what we do with other institutions all over the world, and in a couple of cases in my personal capacity also, right? So first of all, take note of the top one, the UHCPHCGoogleGroups.com. Take note of that Google group because you can come in and participate in all kinds of discussions related to primary care and healthcare post-COVID. So this will be good for you to come in and know more things about what's going on in the global world, okay? Right. Before I begin, I just want to give you a background of what WONCA means. WONCA, very long acronym, but they shorten it to the World Organization of Family Doctors. And the mission of WONCA is to improve the quality of life of the peoples of the world through defining and promoting its values, including respect for universal human rights, and including gender equity, and by fostering high standards of care in general practice and family medicine. Right, this is the current WONCA executive. The president of the World WONCA is Dr. Ernest Havdal from Norway. Past president is Dr. Donald Lee of Hong Kong. And the incoming president is Professor Karen Flagg of Australia. 3 members at large, Professor Shabir Moses of South Africa, Dr. Maria Aste from Spain, Professor Valerie Walsh from the United Kingdom, and the chair of the Young Doctors Movement, Dr. Shankar Landilukumara. The regional presidents from Africa, Dr. Dana Bubaka, Nigeria, and myself representing the Asia-Pacific region, Professor Tagrid representing the Eastern Mediterranean, she's from Egypt, and Professor Shlomo Venko of Israel representing the European region. The CEO is Haris Lidigakis from Greece. The Ibero-Americana is Professor Jacqueline Ponzo of Uruguay. North America is represented by Jeff Markins of USA, and South Asia, Dr. Tariq Aziz of Pakistan. So very, very much international. Now, this is the current Asia-Pacific region that we are heading. I'm the chair, I'm the president, and the secretary, Dr. Kavya Rasan of Malaysia, and the treasury, Dr. Brian Chang of Taiwan, and he's the incoming president also. We have 4 members at large, Dr. Aileen Espina from the Philippines, Dr. Tin Meo from Myanmar, Yang Hua from China, and Dr. Frank Jones from Australia. And the chair of the Young Doctors Movement in the Asia-Pacific region is called the Raja Kumar Movement, is Dr. Wong Ping Fu. So this is our area which Indonesia is included in. As you can see, it's basically divided into 3 groups of regions: Northeast Asia region, Japan, Hong Kong, Mongolia, China, and so on, and us in the middle is the ASEAN region, and below is the Austronesian region. Now, I have been associated with the Indonesian Association of Family Doctors since the year 2006. And Indonesia became a WONCA member in 1982, and they first hosted the WONCA Asia Pacific Region Conference in Bali in 1990, and recently, December last year, 2022. Currently, they have about 800 members, with 550 of them already family medicine specialists. Now, Indonesia has a vast number of primary care GPs, 120,000 of them, I'm told, And this is a vast potential for Indonesia to train family medicine specialists and raise the primary care services delivery. Right. Last December, our Indonesian colleagues organized the Wonka Asia Pacific Region Conference. Looking at the discussion on the post-COVID, first of all, we talked about, there are of course other topics, but focusing on these post-COVID issues, there are two main topics so this is a form of collaboration between Indonesia and the rest of the Asia Pacific region. One is the family medicine practice in the post-COVID era to support universal health care. And it goes down to looking at system design for enhancing equity and coordinated care of the post-COVID-19 syndrome in primary care practice. Now, the other one is having a smart clinic electronic medical record in primary care using ICPC code or ICD-10. And this was presented by our Indonesian colleague. And another one is the role of family physicians in the UHC in the Philippines. So we exchange ideas, we exchange our practices. All this happens as a result of COVID. And another area that was importantly discussed was how to build a family physician's competency in the post-COVID world. So these are Canadian consultants who came in. How can your family physician competencies change the post-COVID world? So in the Asia Pacific region, this is what we collaborate with. Every conferences, as the theme of today's conference is post-COVID issues, so I just want to highlight what kind of post-COVID issues have been discussed. And this is how Wonka Asia Pacific region collaborates amongst its members. Like any other conference, there are other interesting topics, but on post-COVID issues, we exchange ideas. What happened, what happens last time, what is happening now, and what can we do for the future. Right, so this is one example. And your Indonesian colleagues are being very, very active now. And I think they're getting a lot of support from the Ministry of Health. Now, at the same meeting in Bali, we managed to get a Zoom meeting with the Indonesian Minister of Health, Bapak Budi Gunadi Sadikin. And there you can see is Dr. Anas Abdul and Dr. Isti Fujiati and Professor Darini, I think she's somewhere around here, and myself and the Canadian group, and we were talking. And Pak Budi has strongly supported us, and he actually wanted primary care transformation in Indonesia to be accelerated, and in some ways he wants the assistance of Wonka to help the Indonesian family doctors. Okay. Now, as a result of this meeting, the minister himself suggested that they have a separate meeting with Wonka and the Indonesian representatives in Geneva. And the meeting was held in Geneva. I was not able to attend this meeting, but as you can see, the minister himself and representatives of the Indonesian Ministry of Health and the PDKI doctors were there. So that goes to show how much the current Ministry of Health is emphasizing its importance on family doctors training. You already have a good BPGS program, so all the more reason now your primary care services has to improve much more. Now, research as far as Wonka is concerned, we have several working parties and special interest groups. Now, one important working party is the research working party, and this focuses on global research, global collaboration amongst members and amongst other institutions. So I wanted to focus on this, the one highlighted in green, and that's where, since the topic is on collaboration in research and practice, this is the way we do things in Wonka. Right. One important research that Wonka did just after the COVID-19 epidemic was led by a team headed by Professor Goodyear Smith. She's from New Zealand and her team. And this was a follow-up survey on an international COVID-19 primary care pandemic response study. And as a result of this study, she gave a report that states, number one, there is insufficient remuneration for primary care providers for remote services. Perhaps some of you here are in the rural areas, and you probably know what it means. Not enough payment, not enough support in all kinds of situations. So this is one of the important results that was observed post-COVID amongst the APR region. Equally important, the involvement of primary care in vaccine delivery results in better vaccination rates. So I don't know what is the Indonesian experience here among general practitioners, but in Malaysia and some other settings, we find that for effective immunization, it is the involvement of primary care doctors like GPs and family physicians that gives a better outcome and better take-up rates. So that's a third important observation that was made. And fourthly, as a result of COVID, I think most of us know, there has been increased use of technology by primary care providers. You and I think, have been involved in this. If you're teaching, of course, you have to do online teaching. And as BPJS has also done, they realize the importance of data technology. So these are important issues that we observe as a result of the collaboration. Right, another study by the same group, almost the same group, but it's led by Felicity again. The relationship between the perceived strength of countries' primary care system and COVID-19 mortality, an international survey study. Perhaps this is related to what Dr. Fabi was saying about United States having a supposedly strong primary health care system, but which proved to be a myth, isn't it? So the report stated that, number one, a strong primary health care includes public health and primary care, right, is a cornerstone for achieving universal health coverage. And the existence of a prepared pandemic plan and a strong PC system does not necessarily lower the mortality rates. In relation to you, I think this is evidence enough. But what is more important actually is how the primary health care was mobilized in response to that situation. That is important. Number three, border closures. As you can see, some countries that fail because they don't close their borders very fast. And then you must mobilize your primary health care to reduce the hospital burdens. There has been a shift. The hospitals, we do observe, was that there's been a lot of cases admitted into hospitals, which is curative, and then the government clinics have to take over all the other supposedly inpatients and manage them. Whereas what should be done was, of course, that the focus would be on the primary care clinics, you know. So there's been a lot of misjudgment, may I say, on that, in the handling of these kind of patients, and that was one important lesson we learned. And then, of course, the practice of hygiene, physical distancing, testing, triaging, contact tracing, and so on. All of us have been practicing, as you know. But of course, it's a question of accepting the practices, masking and all that has been. Of course, vaccination has not been, has been quite controversial in some regions, as we know it. Right, in relation to the same study, look at this, all those in red, where are they from? The highest is in Belgium. Malaysia stands very low, where our mortality is extremely low. This is by mortality by country, on the left column. Indonesia did not participate here, I think, but Malaysia and Singapore were in the blue line. So we were pretty lucky in that sense. The middle column shows you the strength of your primary care system versus the maximum COVID-19 mortality by country. Now, Malaysia and Singapore falls into what is described as the moderate strength system. Professor Goh? And as you can see, both of us, Malaysia and Singapore, are doing pretty well there on the left side. Again, unfortunately, Indonesia did not participate. I wonder why. And thirdly is the pandemic plan execution versus the maximum COVID-19 mortality rate. Again, in the last square, you can see like a SWOT analysis square on the right lower quadrant. Again, Malaysia is there, which shows that we executed the pandemic plan well, and the mortality was low, as compared to the top left hand, right, where countries have a pandemic plan but they do not execute, they have high mortality. On the right is they executed the plan but they have high mortality. And lower down, of course, on the left is pandemic plan was not executed, but for some reasons have low mortality. But Singapore and Malaysia fell into the right lower quadrant. So we're pretty lucky in that sense, not much mortality, and I think there were a few series of lockdowns, not to everybody's convenience, but I think it serves its purpose. Right, another article. There are a couple of articles which you can look into. Integrating primary care and public health to enhance response to a pandemic. Now, what is the most important lesson learned here is that it is just not primary care alone that's important. We've seen the greater importance of public health. So no one can say that primary care is important or the other side says I'm more important. It is not. Both are equally important. So we have to learn to work together. And the lesson, most important lesson here is how does primary care and public health work together? So that is one important lesson for us to know. Right. And there's another series of studies below, which is multinational primary health care experiences from the initial wave of the COVID-19 pandemic qualitative analysis. So many others, but this is what WONCA does, collaborating amongst its members as well as other institutions. Right. Currently, one active member of the Working Party has been doing a series of webinars. She's my colleague from Thailand, Dr. Sairat Noknoy. Take note of her Gmail, because she has been doing a series of online discussions, webinars, and the most interesting webinar will be coming soon, which is on the 9th of October. How primary care has transformed further in post-COVID era. That would be important, and that many of you here, if you're in primary care, you should get yourselves involved in sairatnoknoy@gmail.com. So again, WONCA has been very active in collaborating with its members and other people all over the world, active response and passive and active response to the pandemic issues. Now, again, focus on the left square. Anna Stavdol, when she took office, these are some of her priorities. But what we learn now from the pandemic response is both primary care and public health must learn to work together. So we are going to run co-trainings for personnel. Right? So certain countries have strong primary care, weak public health. Some may have strong public health, weak primary care. It doesn't matter, but it's both must come in together and prepare for future responses. That is the most critical issue. What we learn is, in most countries, there are two issues. Supposedly strong primary care, like United States, but they fall apart. The other issue is very weak primary care systems also. So right now, COVID has taught us that of all the three services, it is a primary care service that forms the most important in such cases. Not to say that the other services are very unimportant, which is wrong. But in responses like this, there must be a strong public health care team to prepare. So I think many of us all over the world are doing that. WONCA is also making all kinds of suggestions to prepare for the next pandemic. COVID-19 is not going to be the last one. There's going to be more coming on. You can assure yourself, as long as you live on planet Earth, that's what's going to be, right? Now, the other form of collaboration, which I personally am involved in, is the Tripartite Postgraduate Forum on Health Systems and Policies, which is my personal interest. And if you can see, my supervisor in my research is Professor Said Al-Junaid. He is a good friend of Professor Ligufron. He is the advisor, actually, to the Indonesian BPJS. Indonesia, to its credit, with all its hundred thousands of islands and multiplicity of complexity of population, due credit must be given. I've heard Prof. Ali Gufron, we had a formal economics conference a couple of years ago, and I already knew that the social health insurance has been very successful. Now, social health insurance is my personal interest, and Prof. Al-Junaid and I are trying to push in social health insurance into the coming systems in Malaysia. Malaysia has been talking and talking about social health insurance. We keep on talking about our good neighbor Indonesia, but jump across us and we're just looking with our mouth open. You know, so I think this time is going to be real. But there's been certain political changes, as you know, but we're not going to let it go this time. And UGM is represented by, I think many of Indonesians will know, Professor Laksono Trisnantoro is also the advisor to the Minister of Health. I've known him personally since I got involved in this. He's also the cousin to our good friend Dr. Danasari of Universitas Indonesia. And the third person is Supasit Panaturai. So, because all of us have different interests, and mine happens to be this, and it actually relates to the Indonesian system. So this kind of collaboration, this kind of multiple collaboration actually is good for our region. So as you can see, some of you will have different interests, but to get to work together, one car is one of the avenues. But specifically, if you're interested in health systems, this is the avenue. But it's between these three institutions. Yeah. Okay. Right. The one that we had just now was in Hatyai, last month actually. Again, the main topic was post-COVID health equity. It's all about post-COVID, what to do next. So, promotion of health equity post-COVID, the issue of equity and efficiency, the pandemic preparedness and the response, the post-COVID research needs and prioritization, role of policymakers and academia for preparedness of new emerging disease. So just don't say end of COVID, no more. There's going to be new ones, so we got to prepare. Now, more of these articles you can search in the Journal of Health Science Research. Okay. Right. Another way of collaborating in my capacity as WONCA president is with the World Health Organization Western Pacific region. I have been in personal touch with these two staff of the WHO, and every year WHO or the WPR Western Pacific region organizes a meeting. But unfortunately, as organizations, we cannot have a direct working relationship because WHO works with the countries, with the states, with the governments, not with us. So ours is more of what they call the non-state actors. So we are working, but to a limited extent. But we are working towards future possibilities, okay? Right. Now, in the two sessions I attended, WHO Western Pacific, the 71st and 72nd session, this was just after the pandemic, we suggested two statements. Number one, that all countries should develop a formal, coordinated, and effective public-private primary care partnerships that will ensure the stability and function of the system to a high level of preparedness for any future pandemics. That was the immediate response during the height of COVID. Next year, following the year, we had another statement submitted. The talk was still unrelated to COVID. One of the most significant observations throughout the COVID-19 pandemic is the lack of emphasis and recognition of family doctors and primary care services in many of these countries. So they put aside the role of GPs and family doctors, and again, it's a wrong shift. And there's a lesson learned. Family doctors and other primary healthcare professionals are central to health emergency risk management, preparedness and communication locally and internationally. The initial COVID-19 response was hospital-centric and curative-oriented, so that should be changed. And as many countries progress to the endemic phase, the role of family doctors is even more crucial, right? So that is why many countries transforming the healthcare services are allocating their budget more on primary care. And that's happening in countries like Malaysia as well. Okay, another institution, or another grouping that we had formed, I think Prof. Goh was also here, is what we call the ASEAN Regional Primary Care Physicians. This actually was mooted after a meeting in Jakarta in 2006. I think some of you may know who the late Professor Azrul Azwa was. Professor Goh and I had a very strong relationship, very close relationship with him. We started this organization in 2007. The one below with the angklung was in Bandung, and in Malaysia as well. So there were a series of such meetings, but this institution has yet to be formalized. So I was hoping to get a chance to meet the new Indonesian minister, because the ASEAN office is based in Jakarta. So this is one area that you all in primary care join your PDKI and get involved with this. There's a lot of potentials in getting involved in such measures. Right. Now, when we established that RPEC 2007, we had a KL declaration. Now, excerpts of this KL declaration, this conference resolves that the general practitioners and the family physicians in the ASEAN region should collaborate in sharing knowledge, skills, educational and research resources to work with the ASEAN Secretariat and the medical associations of Southeast Asian nations and other organizations in which seem fit. So all these are the signatories. All the countries in ASEAN are testimony to this, and all of them are signatories. That was in 2007, right? Recently, with the College of Family Physicians, there's a direct bilateral agreement between us. I've had some discussion with Ligan on this. We hope to carry this further up. Yeah, Ligan? Okay, if you look at our website, this is something important that our society does. We have the Malaysian Primary Care Research Group. Our website is www.afpm.org.my, and they have very, very strong research groups for our members. You can look into that. Right. Now, Indonesia, Malaysia, there's been a latest news report saying that Malaysia and Indonesia will launch an academic institution cooperation. This was Bernama News. This is between the prime ministers and the foreign ministers. So I think we, as institutions, UMM and MAS and my university also, should pursue this further. There are no details, but there's an open concept that they agree, both Indonesia and Malaysia agree to work together, collaborate in research and whatever activities. So we have to pounce on this and take advantage. I'm sure there'll be grants, there'll be all kinds of financial supports. Right. For Malaysia, we collaborate amongst our specialties. Primary care, secondary care, and tertiary care, we are all one family. We work together. That's the Academy of Medicine, this Academy of Family Physicians. We understand the need that all of us are brothers and sisters. There's no discrimination. At the end of the day, all of us want to be specialists in our own right, in our level of services. Because the objective is a seamless, specialized, well-catered services, primary care services, and other healthcare services for the country. Right. So to close it, we are having our new building. The Joint Medical Academies are in unity under one roof. This is almost completed by the end of the year. It's in Putrajaya. On the left is actually the Cancer Institute, and in front is the new Masjid Sultan Tunku Zainal Abidin. So we hope to come again together representing the whole health specialties, primary care, secondary, and tertiary to come together. Right. Now I just want you to show this. This is Kyoto 2005. That's how long Professor Goldie gone. And our gracious. I wish Professor Ali Gulfan was here. Professor Ali Gulfan on my left, Goldie gone. So the three of us actually knew one another since 2006. And again, me and Professor Ali Gulfan in Jakarta 2011. So this is what I call friendship. This is what I call networking, collaborating. Unfortunately, Professor Ali Gulfan, on 2 occasions I've been not able to see him face to face. So that's about it. So remember, these are the kinds of institutions in Indonesia for our Indonesian colleagues. There's WONCA for you to join, and there's RPEC for you to join. So think about it, because this will be good for your professionalism in the future. Thank you.
Thank you very much, Prof. Muhammad Rusni. And the next speakers is Prof. Go Lee Kan from the NUS Singapore, and he will be presenting about the pandemic throughout the 8 lesson learned. Time is yours.
Thank you, Dr. Yoyo, and also thank you, Dr. Henny. Good morning, Prof. Mehdi, Dean of UMM, Dr. Subayat, the Head Organizing Committee, the colleagues, speakers, ladies and gentlemen, and also I must say my wife too. She's here. Okay, so I must begin, and I like to thank Dr. Rubayat for inviting me to come and give this paper. And it is a paper that is important because COVID-19 is one pandemic, but it's not going to be the last pandemic, right? So we need to be prepared for some more pandemics to come, and therefore, what lessons can we learn, and therefore what preparation we can take. I think that follow up onto what Prof. Husni has presented. This is the continuation of the same story, and also what Dr. Femi has told us too. Right? Yes. Okay. So on to the next slide. Oops, sorry. Not so good at this. Okay, so the point to make is that there are a few things to say. First, the background understanding of pandemic. So we have pandemic. There's also this epidemic. So what's the difference? Epidemic is one country. Pandemic is 2 or more countries. And of course, for COVID-19, it's 194 countries, all the countries in the world. Right? So it's clearly a pandemic. Then, in the last 100 years, this flu pandemic was a king. So there was the 1918 flu, they call the Spanish flu. It's called Spanish flu, not that it happened in Spain. Spain was a country that freely communicated with the world, so they call it the Spanish flu. So it's actually a wrong use of the term. But thanks to Spain for being so helpful, people can still communicate. Now that flu pandemic killed 40 million people. So that is certainly a very big number. And of course, into the present, we have COVID-19, and there are 2 other viruses related to it. There's a SARS and also MERS. Okay, then on to the next slide. So what I'm going to talk is that we need to have an understanding of the background, And then how did I get the information for this talk? Well, I searched PubMed, I searched Google, and then the lessons learned in USA, Indonesia, and Singapore were my restricted search because I wanted to focus on these 3 countries. And of course, they end up with the take-home messages, right? It's going back. Okay, so these are 2 pictures I want to show of the pandemics throughout the ages. It's a bit small. So you can see that the oldest recorded pandemic is the plague of Athens, and that is 430 years before Christ. And if you look again, the size of the ball tell you how big is the pandemic. So I can say that the biggest one is which one? The biggest one is the yellow one, the green one, right? The green one, that is a Spanish flu. And then quietly down there, the next biggest one is the one, number 16, the red one. The red one is HIV. Doesn't make too much noise, but killing lots of people along the way. So you've got to watch out on that one too, right? And then you look further down, there is this COVID-19 there. Okay, next slide. Okay, so we said what causes a pandemic? Right? It can be a virus, it can be a bacteria also. In the past, the bacteria were important in the plague, but into today, into the future, I think the virus is going to the one that's going to kill us. And it becomes problematic when the infection can spread from one person to another very quickly, and then also very few people have immunity to it. And of course, that being so, then it is very widespread. Then the only next thing that stands before us and death is it lethal. It can be very infectious, like Omicron, COVID-19, but not lethal. So you have to think of this word, infectious, is it lethal? Is it lethal? Then susah. No? Okay. Why keep on waiting? Okay. Right. So this slide is just to show you again the pandemics in the past. So I want to mention the top 4. So the top 4 that has gone away is actually the Black Death, the plague. And then the smallpox apparently was a problem too, until we have this smallpox vaccine. And of course, then we talk about the Spanish flu and then other flus. No? Okay. Then this next slide shows us the death toll as a percentage of people killed through the ages. So, as I said, the Black Death is the biggest one. And then COVID-19, although it infects many, many people, thankfully, the number of people killed is actually not big, as you can see there. Okay, then next slide. Okay, so what happened? Not so. Okay, so this one is just to list out the number of people who die in each of the pandemic. So from the plague of Athens as the number 1, down to the third plague in number 10. So you can see the number of people killed by the plague is actually a lot, right? Then next slide. Okay, this will bring us to the present. So you have the yellow fever was also some number of deaths, although not so big. Then you have the Russian flu. Then the Spanish flu is the big one that I talked about. Of course, the other flus are so important. There's a Hong Kong flu, and then further down, you have the MERS that I talked about just now, and then now we are at this COVID-19. We have 6.9 million people lost, but compared to the world population, it's actually quite small, thankfully. Okay, so this one I told you already how I search. Okay, so I want to talk about the results of 3 countries. United States, what can we learn? Indonesia, what can we learn? And Singapore, what can we learn? So first, United States. Okay, so there are 4 slides that I have. This paper by Tanya Lewis in the Scientific American, published in 2021, that's 2 years ago, in March 11, is a very important paper to read. Important, why is that America did so badly in this pandemic? So it says that among the biggest shocks on COVID-19 deaths was the US fared worse than most other countries. And on the anniversary of this disaster, Tanya Lewis decided to revisit this and talk about the biggest mistakes and the successes, and so what are we going to do? Okay, so what was important was that United States at that time were run by a president that had different ideas. He didn't think that COVID-19 was important, and he even downplayed the importance and also mocked people who took on preventive measures. Secondly, CDC wasn't doing well. CDC United States, their test was not very good in measuring what is the true state of affairs. And of course, we know that inadequate tracing, isolation, quarantine were all not well done because the Americans pride themselves on personal freedom. I want to do what I want, so what? And of course, then they pay the price for it, quite clearly so. Right, so some more problems. This mask guidance, as I said just now, Trump wasn't very helpful. And the Americans also thought that the hands and the surfaces were the 2 important things. They forgot that the mask was even more important. And forgot that safe distancing was important. So therefore, those are recipes for their failure. Okay, so some other problems. The different sectors of the community in USA also had different defense mechanisms. As Dr. Fabi said, it is a system that COVID-19 exposes the weakness, make it worse than something. So you can see that there was no good. And then each of the states also had different ideas. So sum total is a mess. Okay, so that is America. What did Indonesia do? I got 6 slides. So first is that COVID-19 was confirmed on 2nd of March 2020, and the 2 first people Indonesians got infected was a dance instructor and the mother. They were tested positive, and they were infected by a Japanese national. And then by 1 month, March 2nd to April 9, that's about 1 month, all the 4 provinces in Indonesia were infected. So it's that fast, And of course, the worst hit would be places where there are lots of people. And as you know, it will be Jakarta, West Java, Central Java. So they actually had half of the country's total cases in these 3 places. And this information, I got it from Wikipedia, so it should be quite accurate. Okay, then this is a map just to show us the cases. The one that is darker, the darker the red, the more cases. So you can see that this Indonesia, Java. Java is really a hotspot there. Central Sumatra also a hotspot, and Kalimantan also quite hot. Yeah, so these are the places where there are lots of COVID-19 cases. Then what about deaths? So this one is death as reported on the October the 10th. The black one is a terrible one. So as we expected, because there's so many people infected in Java, you expect Java to carry the biggest numbers of deaths also, which is indeed so. Then what happened? So we can say that as of 2023, July the 3rd, Indonesia reported 6.8 million cases, second only to Vietnam. And the number of deaths was 161,000, the kind of number, and they ranked second in Asia and number 9 in the world. So quite a number of deaths, Indonesia being so big, you see. So, of course, the president was criticized for not calling for national lockdown, but he called for these restrictions, restricted kind of movement called PSBB. Well, he did try to do something, right? Not to say he did not do something. Then, thankfully, by January, things are a bit more peaceful. So President Joko Widodo, in fact, set the example by vaccinating himself in his presidential palace on the 13th of January. And that vaccination program is helpful. Certainly, it helped to slow the infection. And right now, Indonesia is now in an endemic stage. That means the virus is here, but it is okay. We can still continue with our lives. And that is an important stage in our development, because once you say endemic, not going to kill so many people, you are not so scared, life can go on. I think that's important, right? Because one of the side effects of any pandemic is what we call stoppages of business. So that is a big problem. Okay, so we go on to the last slide. So President Joko Widodo officially announced Indonesia's entry into endemic phase, and that was conducted over the YouTube channel on the 21st of June. So as of 21st of June 2023, and now and further on, the COVID-19 is endemic. It is not so bad, we can live with it. Important to wear your mask if necessary, but most of the time, if you feel that it's safe, there's no need to wear the mask if you're vaccinated. So I think that's an important point to make. You're vaccinated, you're okay. No need to wear masks. Okay, so there's a picture of Indonesia. Then what about Singapore? Well, Singapore, well, we did try hard. We are locked down, circuit breaker, that kind of thing. So on March the 8th, the Singapore government decided to issue a white paper to talk about the challenges and how we overcome the challenges, right? And hopefully this will be of some value to the world and to Singapore for the future. So what I extracted from it are the lessons of success. So they said there are 7 lessons we learned they want to share with the world and also share with Singaporeans for the next pandemic prevention. And number 1 is that in dealing with a complex crisis, we should establish upfront which dimension to practice, to prioritize. We need to adapt more quickly to changing situations, not to allow the perfect to become the enemy of the good. That means instead of doing something good enough, it's better to do it perfectly right. So don't waste time. Lesson number 2, we need to strengthen further Singapore's resilience as an economy, society, and a nation to be better prepared for disruptions and to bounce back for the shocks. So that is the second lesson. The third lesson is that we could do more to harness the strengths of the people and the private sector. To do so, the government must develop an ecosystem to support and nurture this relationship in peacetime. You must make friends in peacetime. Then in wartime, you can draw on those relationships. I think this is an important point to make. And then lesson number 4, we need to systematically build up a strong public health expertise. So public health is important. Organization capacity to tackle future pandemics. So population health is going to be an important point to make. Okay, lesson number 5, we need to institutionalize the use of science and technology in pandemic crisis management. So in digital technology means investing in interoperable data system and engineering capacity, as well as ensuring the cyber security of information infrastructure. Long story short, we need to depend on digital technology. I think that is the legacy of the COVID-19. That we found out, hey, this Zoom meeting and all that actually was very, very important. Luckily, we have Zoom, so we can continue to talk even though we cannot meet face to face, you see. Okay, then number 6, we need to strengthen our structures and capacity for forward planning to respond to the next pandemic in a more agile and fluid manner. Obviously, we were not so clever because we missed out the migrant workers' dormitories. I think that was Singapore's point of weakness. So we need to think a bit harder, a bit further and faster. Okay, then last lesson, we have to continue to deliver transparent, clear public communications to build trust and ensure effective response in crisis. I think this was our strong point. We were able to connect with every part of the community, be it private, be it government, be it volunteer, or be it private service. We actually join everybody together. Okay, so these were the lessons learned from the 3 countries, America, Indonesia, and then Singapore. So what take-home messages do I have? Okay, I have a few. First is the take-home message from Anthony Fauci. He gave 5 messages, and I thought important to quote him because he's the #1 scientist in America, the one that had to take care of the country who is really in trouble. So his first lesson advice is expect the unexpected. COVID-19 was unexpectedly terrible to the Americans. Right? Why? Because this safe distancing is important. So that is important. Number 2, act early and fast. Number 3, vaccine. Number 4, data and facts. The Americans didn't have very good data and facts. And then number 5, to tell everybody you can prevent a pandemic. I think this is a very important message that each of us in Mother Earth has a place to play, a role to play. Okay, then the other messages, I just added on for what he has said. So his top 5, I will take home seriously. Top 5 messages from Anthony Fauci for America. Okay, so number 6 is support one another to understand the right things in the infection control, which is wearing of masks, hand hygiene, and safe distancing. What I summarize as MHS, mask, hand sanitation, and this safe distancing. Then the next point to note is that state and people must work together to preserve continuity of business and social service. So continuity of service, social service must continue regardless of whatever problems we have. Right? because without that, then the whole country will come to a standstill. And then lastly, the world need to stay united. I think that is also very important. I think this is my last slide. Yes. Thank you very much for your attention. Right. Thank you. Yes.
Thank you very much, Prof. Go, from the next presentation. Now, if there anyone to have any question from the participant, maybe only 2 questions, maybe.
Assalamualaikum warahmatullahi wabarakatuh. Let me introduce myself. My name is Akbar, and I'm a 3rd medical student from UMM. My question is for Prof. Go. From the last slide, maybe. My question is, how we expect the unexpected? You mentioned that, I think, from your last slide. Yes. The question is, how to expect the unexpected?
Yes. Thank you very much for that question. I think that question is very, very important. How do you expect the unexpected? Well, the first thing I would say is that look around to see whether there's anything that can give us a clue, right? So, for example, if you take COVID-19, what we found was that, hey, this virus is actually quite big. And if you wear your mask, you can actually prevent it from spreading. And that's important information, right? So the unexpected is that here is a virus that can catch you with your mask. Provided you wear it properly. Okay, that is the first thing that we learned, which is unexpected. This virus is big, can catch it with a mask. The second thing that's unexpected is that safe distancing is the way to go. Right? That means we know that about 2 meters, beyond 2 meters, the number of people infected is cut down by a lot. This was discovered quite early on. So I suppose the Singapore government, the scientists, as well as the medical people did capitalize on this. So an unexpected thing is that, hey, this is a large virus, can caught by this surgical mask, good enough to catch it. And safe distancing is also good enough to prevent it. I think those are the 2 things that were unexpected, that we did well. Then, like anything, we always got something we didn't do so well. So the migrant workers, we forgot, hey, we got 30,000 of migrant workers. We didn't think of how to get them from infecting one another because they stay so close together. See? So that was something that said, hey, next time, must not forget the migrant workers. Over to you. You want to say something?
Okay. The next question, maybe.
Question.
Okay.
Maybe I will ask the question.
Okay.
Thank you, Prof. Husni. Maybe I will introduce myself. My name is Rubayat from FKUMM. Because the topic from Prof. Husni is about global collaboration and cooperation in health research and practice. Maybe this is not a question. This is maybe, if you don't mind, for Prof. Husni and also Prof. Go, if you don't mind, we may have good collaboration for the research and another activities on academic activities, not only for Faculty of Medicine, but also in general for UMM. If you don't mind, we will have a good collaboration for Singapore and then for the Malaysia, Cyberjaya and US. Would you mind if we ask the request about collaboration for the next time, maybe this year and also another year. If you don't mind, we will have another activities to have a good collaboration about research, about especially about pandemic, about COVID. I believe that in Malaysia and also in Singapore, the data about COVID is quite good, and we will have it for the resources for the next pandemic, for preparation, how we can get the prevention, but also from another non-communicable disease such as diabetes, such as hypertension, because those diseases in Indonesia, it's still very prevalent. If you don't mind, Prof, maybe you will have a statement about my asking about that.
Are you asking me to come back to Malang again? I say yes. Well, my university is a private university. I was a deputy dean of administration and external relations, 2017 to 2019. We had a lot of Indonesian universities coming. We had MOU, Unisba, Brawijaya came, although I was not around then, so many. We are more than welcome. We look forward to collaboration. In my case, of course, I'm representing, today I'm representing Wonka. My term ends next month, October, in Sydney. As you said, as I also said, we have the ASEAN group. We're closer in that sense. So anytime, just tell us, but you need, we need to know what you want, and if you think of some regular collaboration, it has to be, there's an MOU and all that, so we can follow up after this. As it is, I told you about between Malaysia and Singapore, Indonesia is already a general official support that both countries, academics, have to go in. So, but no details, but it just means that I should think the funds are available. You know, when both governments agree on this. That last slides I showed you said about the visit of I think Professor Dr. Jokowi and our Prime Minister Anwar Ibrahim, and then both foreign ministers followed up. So that was actually a strong agreement to encourage all academics in Indonesia and Malaysia, whatever disciplines it is, to come and have a real strong engagement. Singapore will probably have another one too as well. So it's all in the ASEAN spirit actually at the moment now, isn't it? So just write to us and we can talk, we can Zoom if you want to.
Thank you, Prof.
Buy us a ticket to Malang and we'll come anytime.
Okay, so I just add on to say that I certainly share the same sentiments as Prof. Husni. In fact, going back to history, the first time I came to Indonesia was 1992. So that's about 30 plus years ago. Because in Singapore, we had this Singapore International Foundation, so I was invited by our SIF to talk to Indonesians on the idea of family medicine. So then we decided that the insurance system, the workplace insurance system, is probably the best place to introduce family medicine, primary care. So you can see the result of what Mr. Dodi presented is certainly quite a good success that we decided way back in 1992. Okay.
Thank you very much, Prof. Go and Prof. Husni. Maybe we hope the collaboration is doing in the next year, maybe. Yeah. And now time is up. So thank you very much for the interesting presentation. And we hope your information can be the make a motivation to our practitioners in here. So thank you very much, Prof. Guru and Prof. Husni. Terima kasih. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Ryoyo, for moderating this session. And of course, thank you very much, Prof. Husni and also Prof. Go for the great presentation and also the attractive interactive discussion from all of the audiences. Well, ladies and gentlemen, after this we have some minutes for duhur prayer and also lunch break, so you can enjoy your lunch and also have some rest in the session. Please come back to the ballroom at 12:50 p.m. and after lunch break we will continue to the next session. We still have three speakers left for this conference. I hope you can enjoy your lunch as well, so we can be more attractive to face the next session. And the next session will be guided by Dr. Anissa. We'll be right back. See you again in the next session at 12:50 p.m. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Tempat tinggal kita tanpa hiasan, tanpa lukisan. Beratap jerami, beralaskan tanah. Namun semua ini punya kita. Memang semua ini milik kita sendiri. hanya alang-alang pagar rumah kita, tanpa ajaib, tanpa melati. Hanya bunga bakung tumbuh di halaman,
namun semua itu punya kita.
memang semua itu milik kita. Lebih baik di sini, rumah kita sendiri. Segala nikmat dan anugerah yang kuasa, semuanya ada di sini. Rumah kita. Haruskah kita beranjak ke kota yang penuh dengan tanya? Lebih baik di sini, rumah kita sendiri. Segala nikmat dan anugerah yang kuasa, semuanya ada di sini. Rumah kita ada di sini.
sesudah kesulitan itu ada kemudahan. Begitulah janji sang pemilik semesta, 2 kali Allah sebutkan dalam surat yang sama. Maka yakinlah bahwa semua kesulitan ini akan berakhir dan kita semua akan menemukan harapan di esok hari. Teruntuk para sejawatku, ingatlah, Allah tidak akan membiarkan kalian menghadapi ini semua sendirian. Doa kami akan selalu menyertai.
Gelisah ku menanti tetes embun pagi, tak kuasa ku memandang datangmu matahari. Kini semua bukan milikku, musim itu telah berlalu. Matahari segera berganti, badai pasti berlalu, badai
Ini masih full.
Itu semua? Oh, nambah satu nih.
really know how it spread pandemic. So in some cases, patients can stay on this side.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Welcome to the second session of the third International Conference on Medical and Health Science, Global Health Challenges and Innovation in the Post-Pandemic Area. My name is Anissa Hasanah, medical doctor, pediatrician. I'm as a master of ceremony in this session. We will have three great speakers in the second session. Please welcome. First is Professor Dr. Ignatius Sutapa, MSc, Dr. Sasmoyo Widito, cardiologist consultant, FIHA, FIACC, FAPSIC, FSCA, and today he will be presented by Dr. Valerina Yogi Buana Swastika Putri, cardiologist FIHA. And the third speaker is Dr. Febri Endra Budi Setiawan, MKes, FISPH, FISM. Okay, the second session will be guided by Dr. Anissa Nurul Arafah, medical doctor, neurologist, Magister of Biomedics, Fellow of Epilepsy, Fellow of EEG, as a moderator. She graduated from the Medical Faculty of Universitas Brawijaya for the General Practitioner, Neurology and Master of Biomedical Science degree. She is as a neurologist in the Sever Hospital in Malang and also a lecturer in the Medical Faculty of Muhammadiyah University. Please welcome Dr. Anissa Nurul Arafah on stage. Time is yours.
Okay, everyone. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Welcome to the second section of the third International Conference of Medical and Health Science with the topic Global Health Challenge and Innovation in the Post-Pandemic Disease. My name is Anissa. I will be your moderator in today's session. We have three below speakers in this session. I will introduce them. The first speaker is Professor Dr. Ignatius Sutapa, Magister of Science. He is an Executive Director of Asia Pacific Center of Eco-Hydrology, UNESCO C2CC. Please have a seat in the podium. And the second speaker is Sasmoyo Widito, Medical Doctor, Cardiologist Consultant, Fellow of Indonesian Health Association, FAACC, APSIC, FSAII. He is the chair of the ED, Indonesian Medical Association, branch of Malang Raya. This afternoon, he is represented by Valerina Yogi Buana Swastika, medical doctor, cardiologist, fellow of Indonesian Heart Association. Please have a seat. And the third speaker is Dr. Febri Endra Putri Setiawan, medical doctor, Magister of Health, FISPH, FISCM. He is the head of Public Health Department in Medical Faculty, Universitas Muhammadiyah, Malang. Please have a seat. For all the participants, you are encouraged to ask questions, share your thoughts, and present any relevant example. This is meant to be an interactive discussion, so don't hesitate to contribute your insight. The Q&A session will be held after three topics have been presented. Thank you for your attention and participation. Now it's time to hear from our first speaker, Professor Dr. Ignatius D.S. Tuapa, Magister of Science. He will be presenting about addressing stunting as a global health challenge in post-pandemic era. Professor Ignatius, the time is yours.
Thank you, moderator. Would like to thank you, the Dean of Faculty of Medicine, for inviting me to this very important meeting, seminar, international seminar. Good afternoon, everyone. I hope that we could enjoy this seminar, and because of most of us are Indonesian participants, so let me speak in bahasa or could be double language. Yeah, I already have my slide in English, but you know I quite could be highlight the important things related to stunting in our country, with of course different perspective. So the title of my presentation today related to addressing stunting as a global health challenges, of course, in the post-pandemic era. So Bapak Ibu sekalian, ini kayaknya semua orang Indonesia ya. Selamat sore dan salam sejahtera untuk kita semua. Jadi tentu saja masalah stunting ini tetap menjadi perhatian kita, termasuk perhatian dunia. So I very much appreciated to this conference to address really as a topic to be discussed in this seminar. Next slide, please. Ini just to show you the outline of my presentation. Next slide. As we already know that stunting is, of course, as medical doctor in this forum, we can define what is stunting definition. Pada dasarnya Bapak Ibu sekalian, ya stunting bisa kita definisikan pertumbuhan yang keluar dari kaidah-kaidah normal ya, dengan mungkin secara fisik, secara mental dan sebagainya. Jadi barangkali ini yang mungkin menjadi perhatian kita, apalagi nanti ada beberapa data kita setelah pandemi ya, itu barangkali kita belum punya data yang lebih detail, tapi coba kita lihat bersama. Intinya apabila hal ini tidak kita perhatikan, maka kita berpotensi kehilangan generasi sejumlah mungkin sepertiga barangkali ya. Karena berdasarkan catatan, setiap 100 kelahiran itu kurang lebih 30% berpotensi prevalensi stunting. Sehingga jumlah yang cukup besar sebenarnya. Ini perlu betul-betul mendapatkan perhatian yang sangat serius, gitu. Apalagi di forum semacam ini, gitu ya. Yang penting memang ya kita mudah untuk menstatekan, tetapi sering tidak mudah untuk ditindaklanjuti karena berbagai hal, gitu ya. Next slide please. Jadi main factor and impact ya pada dasarnya dimulai dari malnutrisi, turunannya banyak. Ya, maka para dokter, para spesialis sudah sangat paham, tetapi di dalam konteks itu di masyarakat ternyata sering memang itu tidak dipahami. Bahkan biasanya kalau stunting itu dimulai dari calon ibu gitu ya. Calon ibu yang mungkin asupannya kurang. Ya, ini beberapa catatan, rata-rata dimulai dari ketidaktahuan juga gitu. Ya, kadang-kadang mungkin kondisi sosial, kondisi ekonomi, budaya juga yang mengakibatkan katakanlah gitu ya. Terjadi pernikahan dini, diharapkan atau tidak diharapkan, itu juga sering menjadi pemicu utama. Di dalam kondisi struktur masyarakat kita itu juga tidak mudah. Gitu. Jadi banyak faktor. Intinya banyak faktor bagaimana kita mengurai satu persatu, kemudian kita mencoba mengurangi ya. Memang kalau ini sudah terjadi, ini seperti tidak bisa kembali, kita tidak bisa mitigasi gitu ya. Oleh sebab itu lebih baik dicegah daripada atasi di belakang hari gitu. Lanjut, next slide please. Ini just to show you different figure related to specific area like in our countries, Asia Pacific region, Africa, Eastern Middle Europe, etc. Dan sayangnya memang di wilayah kita itu relatif tergolong masih tinggi di Southeast Asia. Jadi kalau kita lihat rata-rata itu di atas 25% prevalensi stunting. Kita data tahun 2018-2019 katakanlah gitu ya, masih di atas 30%. Ya, mengapresiasi program pemerintah harus diturunkan secepat mungkin begitu ya. Ya, data terakhir belum mendapatkan update-nya, tetapi dengan harapan kita semua pasti turun gitu ya, di bawah 30%. Ya, kalau standar WHO paling tidak harus di bawah 20% lah paling tidak gitu ya. Next slide please. Ini data misalnya Riskesdas, berdasarkan Riskesdas tahun 2018 ya. Ini rata-rata sebagian besar itu di antara 30 sampai 40% prevalensi stunting berdasarkan data yang dari Kementerian Kesehatan gitu ya, dan bahkan ada wilayah-wilayah seperti NTT itu sampai mencapai di atas 40%. Gitu. Itu 18. Kemudian kalau 19, next slide please. Itu juga ya relatif rata-rata memang masih di atas cukup tinggi lah, di atas 30%. Itu berdasarkan Riskesdas 2019. Dengan harapan ada percepatan gitu ya, kalau supaya itu tidak berdampak. Apalagi kalau itu stunting sekarang, kemudian akan menjadi usia produktif di mungkin 20 tahun kemudian, tentu saja itu akan betul-betul berdampak. Apalagi kalau tidak dikurangi misalnya, sepertiga dari 100 kelahiran itu sangat banyak. Ya, tingkat kelahiran kita masih 1,4% gitu ya, cukup tinggi. Sehingga kenapa ini menjadi perhatian kita bersama. Lanjut, next slide please. Bagaimana kalau itu dibandingkan dengan dunia? Ya, this is the figure showing the stunting prevalence among children under 5 years. Lah kalau kita lihat Indonesia itu coklat pekat gitu ya, masih di atas ya itu data WHO berdasarkan tahun 2019, masih sangat tinggi, kategorinya tinggi sekali dibanding mungkin beberapa negara yang lain. Sehingga ini betul-betul harus upaya kita bersama ya, mulai dari edukasi remaja-remaja kita, ibu-ibu yang akan menikah, sampai mungkin usia kritis itu kan 1000 hari kan ya, 1000 days, very very important to be underlined gitu kira-kira gitu. Next slide please. Kemudian ini yang bisa mungkin Bapak Ibu para dokter mungkin lebih memahami, khusus apalagi dokter kandungan biasanya selalu memperlihatkan gitu ya, karena ada kaitannya ya potensi stunting itu dengan anemia ya, khususnya ibu-ibu yang hamil gitu ya. Jadi ternyata relatif tinggi juga negara kita gitu ya, di gambar nomor A ya maupun gambar nomor B. Kalau yang gambar A itu lebih ke anemia dari ibu-ibu hamil ya, tinggi sekali. Jadi ini berarti sebenarnya kurang lebihnya adalah sesuatu yang mungkin bisa dicegah prevalensi ini gitu, karena bisa kita kondisikan sehingga bisa mengurangi potensi stunting pada anak yang akan dilahirkan dengan asupan-asupan yang cukup. Ya memang kalau ya stunting tidak harus di kota, tidak harus di daerah ya, karena berkaitan dengan yang faktor-faktor lainnya, perilaku dan sebagainya. Lanjut, next slide please. Nah ini bottleneck-nya apa? Ya, what is the matter of main factor yang menjadi bottleneck? Kenapa sering menjadi banyak hambatan? Gitu. Nah kalau kita identifikasi diantaranya memang kebijakan, ya, kebijakan yang diadopsi baik tingkat nasional sampai ke daerah. Dalam berbagai kesempatan komunikasi dengan berbagai pihak, ya kadang-kadang stunting itu hanya dibicarakan, tidak sampai bagaimana itu mengatasinya. Gitu. Jadi program nasional, tetapi ternyata kalau kita cek di berbagai pemerintah daerah, ya sepertinya belum paham apa yang harus dilakukan. Gitu. Itu dari sisi kebijakan. Yang kedua behavior, knowledge, kemudian belief bahkan. Karena kita dari budaya yang sangat beragam, kepercayaan itu kadang-kadang juga untuk budaya-budaya tertentu menjadi hambatan. Belum misalnya behavior, knowledge. Sehingga kita juga harus memahami Bapak Ibu sekalian, para pegawai yang di bidang kesehatan misalnya gitu ya. Yang lain juga terkait dengan food system, komponennya banyak. Gitu. Nanti kita lihat di slide-slide berikutnya. Yang berikutnya health systemnya sendiri, ya. Social protection system, kemudian wash system, ya, terkait dengan water, sanitation, and hygiene. Ya. Dan yang tidak kalah pentingnya education system. Jadi ini juga menjadi faktor termasuk bagaimana sih how to increase the awareness of the people in different region in our countries. That's the main challenges. Yeah. Sometimes it is quite difficult to reach our people in different island like this. Next slide please. Nah, bagaimana dengan dampak pandemi? Ya? What will have to do after pandemi era? Jadi pada dasarnya Bapak Ibu sekalian itu juga dikomunikasikan pada G20 meeting yang lalu para menteri Bappenas katalah begitu ya. Itu mengidentifikasi bahwa akan terjadi deviasi, artinya untuk mencapai tujuan pembangunan berkelanjutan yang diantaranya terkait dengan health and well-being, ya berarti terkait dengan stunting diantaranya, ada isu kelaparan dan sebagainya itu ternyata terjadi deviasi, nanti kita bisa lihat. Ya, menteri-menteri Bappenas di G20 sepakat katalah begitu ya, terjadi pelambatan atau deviasi terhadap pencapaian target pembangunan berkelanjutan khususnya di bidang kesehatan. Sehingga ini tentu saja menjadi extra effort to be done in the future after pandemic era. Jadi PR kita bersama lah kira-kira gitu. Lanjut. Ini potret tahun 2021 ya, pada masa pandemi lagi gencar-gencarnya. Kalau diukur ternyata khususnya yang terkait dengan target nomor 2, target nomor 3, target nomor 4, yang terkait kurang lebih dengan bidang kesehatan, pendidikan, terjadi deviasi. Artinya yang tadinya mencapai 100, ya kalau deviasi jadi tidak 100 lagi, kira-kira gitu. Apalagi di bidang kesehatan. Ya kita berjuang keras, ya kita apresiasi kita bisa melewati masa pandemi, katalah dengan baik, katalah begitu ya. Tapi ternyata ada dampak-dampak lain, termasuk penanganan stunting. Sehingga itu tentu saja perlu mendapatkan perhatian lebih di bidang kesehatan. Gitu. Next slide please. Sehingga kenapa kalau di skor ya Indonesia is rank 75 nomornya. 75 out of 163. Jadi urutan ke 75 dari 163 negara. Jadi ya kita ada di tengah-tengah lah gitu ya. Ya karena ya di samping kita juga negara besar, tantangannya banyak, diversity dan sebagainya. Ya, kita ada di situ. Ya, dalam berbagai kesempatan saya mencoba menyampaikan informasi, kita perlu bekerja sama dalam hal ini khususnya perguruan tinggi misalnya. Perlu ekstra keras kerjanya gitu ya. Lanjut. Next slide please. Nah, kemudian bagaimana kira-kira apa yang perlu kita lakukan bersama ya? Dari berbagai aspek gitu ya. Jadi sebagaimana kita ketahui bersama Bapak Ibu sekalian, stunting is a complex problem due to various factors. Ya, such as health status, level of education, socio-economic background, access to foods, drinking water and sanitation, health information and services, institution and government coordination and policies. Bukan faktor tunggal kira-kira gitu. Faktornya banyak, saling terkait dan cukup kompleks. Sehingga paling tidak ya memang ini pendekatannya harus pendekatan komprehensif view, gitu. Tidak bisa sektoral. Jadi untuk menangani ini, how to handle this problem cannot be separated lah kira-kira gitu. Next slide please. Nah, kalau kita lihat berdasarkan data ya, kita speak by data lah ya gitu ya. Dari data-data yang ada, paling tidak dari Riskesdas yang ada, sebenarnya kalau kita lihat cukup menarik ya, selalu ada kaitannya parameter-parameter utama apa yang menyebabkan kasus stunting di Indonesia. Ya, kebetulan beberapa waktu yang lalu saya dipercaya sebagai koordinator PRN gitu ya, khusus masalah stunting ini. Kemudian ternyata menariknya adalah kita harus bagi kasus stunting di Indonesia menjadi 3 wilayah atau 3 kelompok gitu ya. Paling tidak dalam rangka penanganannya. Jadi dikategorikan mungkin low, middle, dan high dari sisi kasusnya. Sehingga penanganan stunting di Indonesia tidak bisa disamaratakan metodenya gitu ya. Ada wilayah tertentu yang sebenarnya informasinya sudah cukup, ya, tetapi ada juga yang informasi sangat sedikit. Sehingga untuk wilayah ini tidak bisa disamaratakan penanganannya gitu. Sehingga itu yang bisa membantu mempercepat penanganan. Ya, yang dimaksudkan low tadi, resourcesnya tidak ada informasi, belum ada upaya-upaya itu dan sebagainya. Tapi mungkin ada yang sudah maju, ada yang tengah-tengahnya, sehingga penanganannya harus disesuaikan dengan kondisi yang ada. Kira-kira begitu, berdasarkan data ya. Next slide please. Nah ini kalau kita sesuaikan pada dasarnya, kalau kita adjust dengan peristiwa COVID kemarin, ya semacam ada apa ya, kondisi waktu yang sebelum COVID stuntingnya sudah tinggi, kemudian masuk ke periode COVID, itu semacam men-trigger gitu ya, karena aksesnya susah, untuk mendapatkan pangan lebih sulit lagi dan sebagainya, sehingga ada potensi untuk peningkatan yang tajam, gitu. Kira-kira gitu ya. Jadi ya intinya kurang lebih asupan malnutrisi itu yang menjadi faktor utama di samping yang lain. Asupan itu termasuk misalnya makanannya ditambah sanitasi dan sebagainya gitu ya, yang tidak merupakan faktor yang berdiri sendiri, kira-kira gitu. Next slide please. Sehingga ini yang paling tidak ya, ini berbicara di para medical doctor, jadi bukan hal yang sulit lah ya, bahwa pada prinsipnya kalau asupan itu cukup dari berbagai komponen, mestinya potensi stunting itu bisa diturunkan gitu. Tapi memang bukan hanya asupan, ada faktor-faktor lain yang harus dipertimbangkan. Next slide please. Nah ini prinsipnya ini, kalau conceptual frameworknya ya quite complicated, parameternya banyak. Ya, tapi paling tidak kalau kita cuplik 3 klaster penting, ya, the main factor related to nutritional intake, 1, asupan. The second one is related to parenting, behavior. Dan ternyata itu pegang peranan yang sangat penting, karena stunting bisa terjadi di daerah-daerah urban, metropolitan, berdasarkan data ada. Jadi bukan karena kemiskinan kadang-kadang, tetapi lebih ke perilaku, parenting, asupannya tidak tertata misalnya gitu. Kemudian yang ketiga baru WASH system. Jadi 3 klaster utama ini yang biasanya mengakibatkan stunting di Indonesia relatif tinggi. Dalam berbagai kesempatan kami juga diskusi di Kementerian Kesehatan untuk hal itu gitu ya. Nah ini hal-hal ini yang harus diurai satu persatu. Next slide please. Kemudian apa kira-kira yang bisa mendukung, ya waktu itu karena kita mencoba kira-kira dukungan apa yang dibutuhkan termasuk research and innovation, karena ini forumnya forum perguruan tinggi misalnya. What will we do in the future misalnya. Sehingga mungkin perlu grand design supaya stunting kan bukan hanya saat ini saja. Kita harus memprediksi jangan-jangan nanti di dekade selanjutnya bisa terjadi. Oleh sebab itu we must build a grand design, a national grand design how to avoid stunting prevalence in the future, kira-kira gitulah. Jadi membuat itu, kemudian membuat peta jalannya, ya supaya itu terhindarkan, kira-kira gitu, secara komprehensif. Next slide please. Nah ini saat itu ya kami mencoba mengidentifikasi, we have identified at least 5 major topics, ya, related to we call work breakdown structure. Kemudian itu dibagi-bagi dalam work package gitu ya, dalam rangka sebenarnya kira-kira intervensi apa sih yang dibutuhkan untuk secara komprehensif melakukan percepatan penurunan stunting di negara kita, kira-kira gitu. Jadi kita coba misalnya improving community nutrition sebagai salah satu WBS. The second one is development of biofortification technology based on a diversity of local resource. Improving food safety and quality guarantee misalnya. Kemudian improving WASH system, coordination of food and nutrition development, ya. Jadi bagaimana mengkoordinasikan dalam sistem-sistem yang ada. Kemudian development of local food innovation. Jadi yang menjadi permasalahan Bapak Ibu sekalian, seringnya akses terhadap sumber pangan itu terbatas, apalagi masa-masa pandemi kemarin. Lah, itu perlu didiversifikasi sumber pangannya. Bahkan kita waktu itu mendorong supaya lahan-lahan yang kosong di sekitar rumah bisa dipakai untuk menanam sumber-sumber pangan yang dibutuhkan supaya tidak terkendala manakala ada saluran distribusi yang tersumbat. Next slide please. Apa yang kita harapkan ya, by doing this ya, the WBS output target synchronization misalnya, itu produk, ada roadmap, intervention model, teknologi, konten, SOP, etc. Jadi kita berharap ada semacam model penanganan secara komprehensif, a comprehensive model how to manage the problem of stunting in Indonesia. Jadi kurang lebihnya gitu ya. Karena selama ini mungkin ya ini berdasarkan komunikasi dengan berbagai pihak termasuk kepala daerah gitu ya. Masing-masing kayaknya menerjemahkannya sendiri-sendiri gitu loh. Bagaimana ya? Pokoknya adalah kegiatan. Lah, yang menjadi persoalan ternyata setelah dicek tidak menyelesaikan permasalahan tadi gitu. Jadi sepertinya memang harus ada model Ya, ini mungkin menjadi bahan kajian fakultas kedokteran gitu ya, dan mungkin fakultas fikes yang terkait gitu ya. Model-model itu ya, memang kita belum punya model yang komprehensif lah untuk penanganan ini secara masif gitu ya, secara nasional. Nah itu yang dibutuhkan. Next slide please. Nah diantaranya Bapak Ibu sekalian, masalah utama pada saat pandemi itu adalah ada keterhambatan akses kepada sumber-sumber pangan dan yang terkait. Sehingga salah satu strategi penting itu food diversification strategy. Nah, strategi untuk mendiversifikasi sumber pangan berbasis local resources. Ya. We should emphasize to use local resources in our region. Ya. Di dalam berbagai kesempatan saya sering menyampaikan bahwa sumber karbohidrat itu bukan hanya beras misalnya. Ada ubi, ada singkong, ada jagung, ada sorghum yang sebenarnya kurang lebih nilai gizinya sama. Sehingga saat-saat tertentu kita butuhkan, ya kalau memang tidak ada ya kenapa kita tidak kembangkan sumber pangan yang lain kira-kira gitu. Next slide please. Gitu. Jadi ini availability and food consumption pattern sayangnya ya berdasarkan kajian itu tingkat diversitas sumber pangan kita itu sangat terbatas. Sebagian besar misalnya sumber karbohidrat bertumpu kepada beras misalnya gitu ya. Ya, depend on certain commodities especially rice. Up to 80%. Tinggi loh. Ya. Dan itu berdasarkan catatan kan kurang sehat sebenarnya ya. Lebih sehat kalau didiversifikasi misalnya. Itu yang pertama. Yang kedua, high food import. Jadi komoditas kita juga sering bergantung kepada impor ya. National food needs still depend partly on import ya. Tinggi sekali. Which reach up to 77.5 triliun per year. Tinggi. Ya. Kemudian juga low information and literacy. Jadi memang tingkat literasi itu juga ikut menentukan ya, terhadap apa yang terjadi. Jadi ini 3 hal ini yang barangkali perlu disentuh ke depan. Ya. Termasuk misalnya kalau ya melalui misalnya konsultasi kesehatan gitu ya, kalau para dokter kan menitipkan pesan lah gitu. Next slide please. Ya, ini misalnya contohnya ya, contohnya untuk menunjukkan supaya ada datanya import of food commodities ini tinggi sekali, misalnya begitu. Nah ini paling tidak untuk mengubah strategi supaya tidak ketergantungan, mengapa kita tidak kembangkan local resources as a food source gitu. Next slide please. Gitu, daging, kemudian dan sebagainya, lanjut saja. Next slide. Lah problem profile of agriculture in Indonesia itu juga ikut berkontribusi. Apalagi untuk wilayah-wilayah tertentu gitu ya, wilayah-wilayah yang jauh. Oleh sebab itu I very much appreciated misalnya pemerintah sekarang untuk membangun infrastruktur yang sangat banyak gitu ya, to facilitate the mobilization of different source gitu ya, related to food etc. Misalnya sering terjadi hambatan apabila tidak ada sarana, misalnya untuk jalan membawa logistik tidak bisa, ada mungkin resiko crop failure, gitu. Kemudian macam-macam lagi, fluktuasi harga pangan di masa-masa sekarang tiba-tiba tinggi harga beras, tapi kadang-kadang tidak ada sama sekali gitu. Next slide please. Sehingga apa yang harus kita identifikasi terkait dengan government policy, constraint, opportunity, and threat-nya berbeda-beda. Jadi, we have to identify different aspect related to the problem of stunting in Indonesia. Yeah. Next slide, please. What are the recommendation and next steps? Ya. Kita kurang lebih Bapak Ibu sekalian masuk di era yang kadang-kadang kita semacam dipaksa, the technology disruption. Ya. Jadi masa kemarin, ya seperti yang kita menyadari juga masa-masa pandemi kemarin kan kita serba dipaksa untuk beradaptasi dengan serba online itu. Baik untuk education, komersial, etc. Nah, ini ternyata bisa menjadi sarana harapan kita itu loh, untuk melakukan percepatan-percepatan. Transformasi digital ini perlu kita manfaatkan di dalam rangka untuk mengatasi permasalahan stunting. Misalnya identifikasi lebih detail, lebih cepat gitu ya. Kadang-kadang informasi stunting itu datangnya terlambat. Ada keterlambatan informasi misalnya, oh anak ini ternyata stunting, untuk disampaikan kepada pihak-pihak terkait misalnya. Lanjut, next slide please. Sehingga era ini we have to use the opportunity of digital transformation as new tools to help us to overcome the problem of stunting in our country. Ya ini sekarang human capital, smart industry, smart city dan sebagainya itu menjadi sarana mestinya yang baik untuk menangani permasalahan. Next slide please. Nah, untuk itu Bapak Ibu sekalian kita harus inline sekarang dengan 3 hal yang penting ya, 3 main areas of digital transformation yang mau tidak mau sedang terjadi sekarang, tetapi harus kita adjust. Yang pertama misalnya bidang policy and regulation. Jadi ngobrol-ngobrol dan Bu Valeriana tadi, misalnya ada undang-undang yang baru terkait dengan kesehatan. Itu sebenarnya dalam rangka untuk melakukan percepatan-percepatan misalnya. Ya. Policy and regulation serve as guide and reference for all parties and sectors. Ya, kadang-kadang kalau tidak ada aturannya susah juga sih. Gitu. Yang kedua, technology and infrastructure. Ya, we should adjust with our era now by using appropriate technology and medical matters, for example. Ya. Tapi juga business and process. Jadi paradigma kita juga harus di-adjust. Jangan sampai kita sudah di era sekarang, paradigma kita masih paradigma yang lalu, kayaknya nggak bisa lagi. Next slide please. Sehingga ini agak campur-campur ya. Tapi paling tidak kita harus meningkatkan kapabilitas, kapasitas ya di dalam literasi, kemudian dalam networking, kemudian dalam pendekatan-pendekatan yang baru. In this era now we should adjust by having literasi level, ya kan, capability yang lebih tinggi dengan pendekatan baru, new approach and also networking. Dalam era sekarang sebenarnya kita tidak bisa lagi di dalam silo-silo yang terpisah. Next slide please. Nah, misalnya contohnya ini, Bapak Ibu sekalian, waktu itu karena bagaimana memberikan solusi ya untuk keterbatasan sumber pangan, gitu, akhirnya kita mencoba mencari untuk memetakan, gitu ya, land suitability map. Ya, ternyata ya memang negara kita ini berbeda-beda kesesuaian lahannya. So we have to adopt, we have to adjust. Ya, seperti saya katakan tadi bahwa tidak semua cocok untuk tanaman padi. Ya, kita tidak harus pasahkan misalnya. Ternyata sumber pangannya ada ubi, kayu, jagung. Ini hanya salah satu contohnya saja. Ternyata kita bisa memetakan itu, kemudian kita menyediakan pangan yang cukup, tidak harus menggantungkan dari tempat lain misalnya.
Excuse me, Professor. 3 minutes left.
Oke, good, thank you. Intinya kita harus menyesuaikan dengan local resources. Tidak harus memaksakan misalnya harus dari tempat lain. Next slide please. Ya misalnya we have to identify local resources, the potential local resources, like agriculture, farm, ya. Kalau yang cocok misalnya corn, sorghum, ya tidak harus kita paksakan dengan paddy field misalnya. Dan sebagainya, misalnya farm yang cocok apa gitu. Atau domba, atau ayam petelur, misalnya gitu. Next slide please. Demikian juga pertanian, perikanan dan sebagainya itu sebagai sumber-sumber yang harus kita kelola di wilayah-wilayah tertentu dan tidak harus disamakan dengan wilayah lain. Next slide please. Nah sebagai konklusi atau sebagai kesimpulan Bapak Ibu sekalian, stunting is a complex problem. We have to concern about this. Memang kompleks, bukan persoalan sederhana. So handling this problem need to be done comprehensively and measurably. Terukur. The second one is availability of food source is an important step to support adequate nutritional intake. Jadi pada umumnya memang 3 hal tadi ya, memang utamanya asupan ya. Sumber asupan ini yang menjadi problem, makanya itu yang harus diatasi. Sumber-sumbernya, distribusinya dan sebagainya. The last but not least, diversifying local food source is an important asset for overcoming the problem of stunting in Indonesia. Among others tentu saja. Di samping yang tadi, ada perilaku dan sebagainya, tapi memang khusus di Indonesia berkaitan dengan sumber asupan, berkaitan dengan resources, berkaitan dengan behavior, gitu ya. Mungkin itu Bapak Ibu sekalian, thank you so much for your kind attention and back to you moderator. Thank you.
Thank you, Professor, for your insightful presentation. I'm sure the audience learns a lot from this topic. For all the participants, you are encouraged to ask questions, share your thoughts, and present any relevant example that will be held after all the 3 topics had been presented. It's time to hear from our second speaker, Valerina Yogibuwana Swastika Putri, medical doctor, cardiologist, as the representative for Sasmoyo Widito, medical doctor, cardiologist consultant, fellow of Indonesian Cardiologists Association. She will be presenting about ethics, equity, and justice in global health and healthcare. Dr. Valerina, the time is yours.
Thank you, moderator, and I would like to say thank you to the organizing committee for giving this kind of opportunity for speaking as from Indonesian Medical Association representative. Dr. Sasmoyo Widito, cardiologist, says sorry that he cannot able to be here to attend this meeting by himself because he has to be in another city for the cardiology meeting. So this is my topic today: ethics, equity, and justice in global health and healthcare. And let me allow to speak in you because of most of the participants was Indonesian, and this is related to the regulations in Indonesia. So please let me talk in Indonesian language, bahasa. And because of my presentations is also in Indonesia, I'd like to say a word to the organizing committee and the moderator. Slide, please. This is the kind of abbreviations in the slide. Oke. Campur-campur ya, gado-gado. Tadi saya sudah izin sama Dr. Febri. Jadi medical ethics itu very important in our country because there are 3 kind of topics from beside the ethic, there's also disciplinary systems and also law. Jadi kalau kita bicara dengan etik, berarti ada 3 hal yang harus kita ketahui. Selain ethical medis, disiplin medis, dan juga berkaitan dengan hukum. Di mana ketiga-tiganya semuanya ada instansi terkait. Jadi ada komite etik, kemudian ada komite untuk disiplin, dan kemudian juga kalau lo ada di bidangnya kepolisian dan juga lawsuit ya. Nah, 3-tiganya itu membuat kita bisa berdiri di tengah-tengah, tidak boleh keluar dari jalur, sehingga kita melakukan profesionalisme kita dengan tertib dan berintegritas. Sayangnya seringkali setiap profesi, saya rasa ya, mungkin di sini juga tidak hanya dokter, seringkali justru pelaporan terkait dengan ethical medis itu berasal dari temannya sendiri, kolega sendiri. Ya, mungkin karena tidak disengaja ataupun disengaja dilaporkan ke organisasi profesi terkait dan kemudian ditindaklanjuti oleh organisasi profesi. Dalam hal ini bila dia berkaitan dengan dokter, maka diselesaikan di internal dari ID. Slide. Di sini saya mau menekankan ada kompetensi and we have to make a differentiation between competence and delegation. So we have in our institution for hospital tentunya ada komite medik. Ya, komite medik itu memberikan wewenang kita bagaimana kita memberikan layanan profesionalisme kita. Tetapi kalau kompetensi adalah skill atau keilmuan yang kita peroleh dari pendidikan ataupun kursus-kursus yang tentunya melewati diberikan oleh kolegium masing-masing organisasi profesi. Ada kolegium kedokteran Indonesia KKI dan tentunya itu disahkan oleh negara. Tetapi kalau wewenang harus di setiap hari tentunya berbeda antara kompetensi dan wewenang. Contohnya seperti ini. Saya dokter jantung tapi tidak melakukan intervensi koroner perkutan atau yang bahasa awamnya adalah pasang ring. Nah, jadi ada kompetensi sebagai kardiolog tetapi tidak punya wewenang untuk melakukan intervensi koroner perkutan. Itu contohnya. Slide. Nah, jadi antara kompetensi dan kewenangan tentunya secara keniscayaan setiap hari berbeda. Ada dokter jantung yang bisa melakukan penutupan lubang, ASD, VSD, PDA. Ada dokter jantung yang bisa membaca CT scan bahkan MRI dan juga bisa melakukan pasang ring dan sebagainya. Tetapi mungkin kewenangan itu tidak bisa dilakukan semua kardiolog. Kenapa? Tujuannya adalah untuk keamanan dari siapa? Tentunya keamanan pasien, keamanan institusi rumah sakit atau tempat bekerja, dan tentunya keamanan masyarakat itu sendiri. Slide. Ini adalah contoh beberapa. Apakah videonya bisa diputar? Mungkin kita bisa mendengar beberapa kasus terkait. Di slide terakhir mungkin. Slide terakhir, oke. Boleh yang pertama?
Dibutuhkan ya kata.
Boleh yang pertama dok, sebelumnya?
Dokter yang pernah menangani terdakwa Setia Novanto Bimana Sutarjo tak banyak berkomentar usai diperiksa KPK pada Jumat malam. Bimanes ditahan KPK lantaran dianggap menghalang-halangi penyidikan kasus KTP elektronik dengan tersangka Setia Novanto. KPK menduga ada persekongkolan antara Bimanes dengan mantan pengacara Setia Novanto, Frederick Yunadi. Keduanya diduga bekerja sama memasukkan Setia Novanto ke Rumah Sakit Medika Permata Hijau pasca kecelakaan lalu lintas yang dialami Novanto di kawasan Permata Hijau.
FY dan BST diduga bekerja sama untuk memasukkan.
Jadi singkat cerita adalah bahwa seorang dokter diduga memperlambat atau menghalangi jalannya penyelidikan. Jadi ini juga termasuk salah satu kasus ethical medis ya. Slide.
Untuk menghindari panggilan
Ada etik, disiplin, dan hukum terkait organisasi profesi, dalam hal ini seorang dokter. Boleh kembali ke slide-nya, Dok? Ya, oke. Ya, yang selanjutnya. Ya, jadi intinya adalah bahwa kita dalam melakukan pelayanan kesehatan, dalam hal ini sebagai seorang dokter, tentunya kita harus memperhatikan ketiga norma yang tercantum di dalam slide. Ada norma disiplin medis, kita melaksanakan keilmuan kita tentunya berbasiskan ada panduan-panduan guideline, ada clinical pathway, ada PPK yang tentunya membantu kita dalam melaksanakan pelayanan, dan tentunya harus berada di dalam jalur hukum yang tidak boleh keluar dari garis-garis yang dapat melanggar hukum. Dan yang terakhir adalah norma etika medis, tentunya kita punya buku Kode Etik Medis Indonesia yang tahun 2012. Slide. Nah, ini parameter-parameter yang bisa kita gunakan dalam rangka memberikan pelayanan kesehatan. Tidak semua dokter berada dalam hubungan langsung dokter pasien, artinya tidak dalam kuratif, tetapi juga banyak dokter yang memberikan pelayanan kesehatan masyarakat, seperti banyak dokter di Ikatan Dokter Indonesia, mereka bekerja atau melayani masyarakat di tempat fasilitas kesehatan masyarakat yang promotif preventifnya jauh lebih diutamakan dibandingkan kuratifnya. Jadi kalau kita mau orang lain memperlakukan kita sedemikian apa yang kita harus lakukan, maka demikian pula kita memperlakukan pasien-pasien kita demikian. Jadi ada prinsip manfaatnya lebih dominan apa justru mudorotnya, lebih banyak kerugiannya. Dan tentunya kita harus memperhatikan regulasi-regulasi terkait termasuk pembiayaan. Nanti ada di slide berikutnya, slide. Ya, ini yang tadi saya sampaikan bahwa tidak semua dokter itu bekerja di rumah sakit, tidak semua dokter bekerja di klinik. Bisa saja mereka memberikan pelayanan promotif, preventif yang lebih banyak seperti di puskesmas tentunya. Akan tetapi kalau kita tidak bisa memberikan pelayanan kesehatan yang bermutu, mulai dari anamnesis, pemeriksaan fisik, pemeriksaan penunjang sederhana saja, kita tidak bisa melakukannya sesuai guideline atau buku atau panduan praktis klinis kita, maka tentunya akan mudah sekali seorang dokter berpotensi terkait dengan hukum. Karena antara ekspektasi dari dokter dan pasien itu merupakan kunci utama terjadinya seringkali terjadinya lawsuit, ya. Slide. Nah, komunikasi yang baik tentunya bisa membangun kepercayaan dokter dan pasien. Tidak hanya dokter pasien, tapi juga dokter dan masyarakat secara umum. Di era tadi sudah disebutkan Prof. Ignatius bahwa era digitalisasi, pasien dan keluarganya sangat mudah untuk melakukan sesuatu, mencari informasi, tinggal search di Google Engine gitu ya, tinggal dia mau cari tahu apa. Apakah tapi informasi yang didapat dari sosial media, dari Google itu apakah benar atau tidak, maka kita harus bisa mengantisipasinya. Nah, komunikasi yang baik maka akan bisa menghubungkan antara ekspektasi dan harapan dari pasien dalam hal pelayanan kita. Slide. Nah, ini karena saya dari kardiolog, jadi saya mengambil contoh misalnya seorang pasien datang dengan nyeri dada. Nyeri dada mungkin kita curiga sebagai suatu sindroma koronari akut dalam kondisi emergensi. Kita kasih tahu pasiennya, oh ini harus dilakukan intervensi koroner perkutan primer atau primary coronary intervention segera. Nah, apakah indikasinya, dari mana kita tahu? Dari anamnesis, pemeriksaan penunjang, rekam jantung, dan laboratorium. Tentunya merupakan alat bantu kita untuk memberikan edukasi kepada pasien dan keluarganya. Dan harapannya apabila sudah dilakukan pemasangan ring dengan segera apa outcome-nya dan hasilnya seperti apa, itu harus kita jelaskan kepada pasien dan keluarganya. Slide. Kadang-kadang kalau misalnya kita dengar pasien ini butuh operasi bypass, coronary arterial bypass graft, tapi di fasilitas kesehatan yang di dekat sini, mungkin rumahnya di mana ya, Madiun Ponorogo, yang terdekat mungkin Malang atau Surabaya. Nah, kita harus kasih tahu bahwa kalau fasilitas yang bisa melakukan CABG atau bypass itu adalah bukan di Madiun, tetapi di Malang dan Surabaya. Berapa angka keberhasilannya, prognosisnya bagaimana, itu harus diungkapkan dalam bentuk komunikasi antara dokter, pasien, dan keluarga supaya tercipta kepercayaan dan tidak ada lagi keraguan dalam mengambil keputusan. Slide. Di era National Health Insurance ini atau JKN atau BPJS, tadi saya tanya dengan Dr. Febri, Dr. Prof. Ali Gufronnya masih ada nggak? Ternyata tidak ada, sayang sekali ya. Jadi dokter selain dengan ethical medis juga dipagari dengan sistem pembiayaan. Kenapa? Karena pembiayaan ini dilaporkan kepada negara, dan supaya tidak diduga kita ada fraud atau tindakan kriminal yang sifatnya mencari keuntungan untuk dokternya, ya, dengan mengeksploitasi pasien secara berlebihan, misalnya sudah indikasi rawat jalan tetapi masih tetap dirawat, atau mungkin pemeriksaan yang tidak perlu, tidak sesuai dengan PPK, panduan praktis klinis, mungkin kita harus hindari sehingga kita bisa menjalankan profesi kita tentunya dalam batas etis medikal yang legal. Slide. Nah, ini ada beberapa tindakan kecurangan di era asuransi kesehatan JKN kita. Tentunya kalau kita mau periksakan pasien, mungkin kita harus merasa, coba kalau kita yang jadi pasien, apakah benar ini penting, apakah benar ini bisa menyelamatkan, apakah ini sudah sesuai dengan standar SOPO atau SOP yang ada, apakah benar ini tidak akan melakukan sesuatu yang di luar haknya, ya. Jadi itu tentunya menjadi pagar A sampai G ini adalah pagar kita dalam memberikan tindakan dan terhindar dari kecurangan. Slide. Jadi harapannya dokter atau organisasi profesi lainnya yang berhubungan dengan pelayanan kesehatan harus mempunyai ethical medis dan harus profesional serta persyaratan hukum. Jadi kita kalau mau nyetir mobil kita harus punya SIM, dan tentunya untuk berpraktek tentunya kita harus punya STR dan SIP, ya. Oke, slide. Ini adalah beberapa regulasi yang terkait bukan tentang STR dan SIP atau perizinan, tetapi berhubungan dengan JKN atau National Health Insurance. Terakhir regulasinya, slide. Ada regulasi terakhir yang mungkin kita harus tahu karena berubah-berubah regulasinya terkait klaim National Health Insurance ini terakhir yang Agustus 2023. Nanti dokter bisa melihat bagaimana perkembangan antara klaim inasi bijis di kita. Slide. Ini adalah berita acaranya. Dan tadi yang sudah disebutkan bahwa kita punya buku Kode Etik Medikal Indonesia, Kode Etik Kedokteran Indonesia yang bukunya warna merah, boleh diambil di kantor Ikatan Dokter Indonesia gratis kalau misalnya pengen tahu isinya apa. Jadi ada kewajiban umum dokter, kewajiban dokter terhadap pasien, kewajiban dokter terhadap teman sejawat, kewajiban dokter terhadap diri sendiri, dan tentunya tidak boleh lupa akan janji dokter. Slide. Sebagai kesimpulan, jadi tidak perlu lama-lama ya dok ya. Jadi di global healthcare tentunya nanti tahun depan ya. Tahun depan mungkin sudah banyak dokter asing. There's gonna be doctors from other country that come to Indonesia to practice here. So we have to make a great preparation for ourselves. And also the regulation is still remaining the same for the foreign doctors that's going to be practiced to help practice Indonesia. The regulations will be the same as Indonesian doctors. Jadi regulasi untuk berpraktek, regulasi untuk perizinan antara dokter Indonesia dan dokter dari luar negeri sama. Slide. Ini yang menjadi yang saya berikan gambar merah atau huruf merah, itulah yang menjadi poin untuk global healthcare. Jadi semoga kita bisa bersiap-siap untuk dengan kedatangan dokter dari luar, namun kita tetap bisa mengikuti regulasi yang ada di Indonesia. Slide. Saya rasa tadi ini sudah ya, Dok.
Dokter yang pernah
Mungkin terima kasih. Sekian presentasi dari saya. Thank you.
Dibutuhkan.
Thank you, Dr. Valerina. Thank you for your insightful presentation. I'm sure the audience learns a lot. For all the participants, you are encouraged to ask questions, share your thoughts, and present any relevant example that will be held after all the three topics had been presented. It's time to hear from our third speaker, Dr. Febri Endra Budi Setiawan, medical doctor, Magister of Health. He will be presenting the interdisciplinary approach to health and research and development. Dr. Febri, the floor is yours.
Oke, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. The last presentation. That's right. Okay, thank you for the committee. Give me a chance for speak on International Conference Medical and Health Science at UMM. I was assigned from a committee to provide this material to interdisciplinary. So I give the title my presentation, Interdisciplinary Approach to Health Research and Development. You know, the population in the world every year so increase, especially Indonesia. Right now, totally population in Indonesia but 270 or 280 million. Number 4 in the world. Without Olympiad, we 4th level. Yes. And we know 2-3 years ago we shocked with pandemic. We don't siap, yeah. We not prepare about pandemic. We confuse how handle the pandemic. Tidak pernah kita bayangkan. Ya. Excuse me, I do the gado-gado language. Gado-gado is very delicious. That's right, Dr. Anissa? Yes, Prof. Ko, Prof. Husni, gado-gado is very delicious. Okay, traditional food from Indonesia. Dr. Rubayat like gado-gado. Oke, rekan-rekan sekalian, Prof. Ignatius, Prof. Husni, Prof. Goh, bahwa kita ini sangat penting untuk selalu belajar, selalu mengembangkan ilmu. Apa yang sampaikan nanti akan sangat terkait presenting from Prof. Ignatius dan Dr. Valerina. Kita akan berhadapan dengan satu problem kesehatan yang sangat memerlukan perhatian kita dan we can do it alone. We must together to menyelesaikan untuk finishing the problem, especially stunting. We need much stakeholder. Okay, sebelum kita kupas tentang health research and development, what is research and development? Yeah. Research and development is the translation of idea or discovery. Jadi suatu pemahaman, penerjemahan dari ide-ide kita. For what? For give a product, especially healthcare. How we can handle the problem healthcare in Indonesia. In global health, the end results shall be safe and effective. Apa yang kita lakukan harus aman, karena kita berhadapan dengan hukum, dengan etika medis. Tadi sudah sampaikan oleh Dr. Valerina bahwa seorang dokter tidak bisa lepas dari hukum. Kita tidak kebal hukum. Undang-Undang Nomor 17 2023 is for a polemic in Indonesia. Kita demo ya, sampai Jakarta, Dr. Farina ya. Saya nggak ikut, tapi saya menonton teman-teman ID berjuang untuk bahwa demo itu menghasilkan sesuatu yang bermanfaat untuk kita semua dokter Indonesia. Nah, apapun yang kita lakukan di dalam pelayanan kesehatan, maka kita harus selalu bekerja dengan aman, ya, hati-hati, dan harus bisa diterima dan juga bisa harus dipertanggungjawabkan. Nah, kita tidak boleh lagi bekerja seenaknya sendiri, ya. Kita tanpa perhitungan kita bekerja, kita tidak bisa begitu, ya. Kenapa? Why? Research and development is important because it's crucial. We must be survive. Tidak ada masalah hukum, ya. Saya setengah tahun yang lalu lebih kurang barusan berhadapan dengan hukum. Alhamdulillah mendampingi rekan-rekan calon dokter yang tersandung masalah hukum. But it's a clear. Kita bisa tersenyum sekarang, ya. And then environment is very fast to change. Mr. Febi say itu perubahan lingkungan yang sangat-sangat mendasar sekarang. Jakarta potensi polusi ya Prof ya, polusi. Nah, ini sangat berpengaruh terhadap kesehatan, tidak bisa kita pungkiri. And then perubahan teknologi, competition di antara kita, saling sikut, saling senggol, and tidak bisa kita abaikan preference consumer, perubahan pemikiran dari konsumen kita, era globalisasi. So easy to access to information kesehatan from Google. Pasien datang, dok, saya sakit tipes. Ya, everything information from Google, it's so easy to open from Google. Tidak sulit gitu ya. Ada pulsa, ada akses, ada data. Semua bisa terbuka. Nah, dan hal yang tidak kalah pentingnya adalah kita harus berani apa yang dibutuhkan pasar. Karena kompetisi. Kita di Indonesia ada lebih kurang 81 lebih kurang, ya, fakultas kedokteran, medical faculty. Dan kita akan berkompetisi untuk menjadi yang terbaik, be the best dalam memberikan layanan kesehatan. Nah, tapi kita ada koridor yang harus kita lihat bahwa di situ ada etika, ada medico-legal sebagai seorang dokter. Kita tidak boleh lagi untuk menyatakan bahwa saya lebih baik dari dia. No. Ya. Kasus 1 bulan lalu, satu hal yang simpel bahwa seorang dokter mengatakan penyakit Anda tidak bisa disembuhkan. Sudah menjadi konsumsi hukum. Nah, ini yang harus kita perhatikan bersama, sejawat sekalian. Ya. Pada dasarnya, you have to 10 step for research and development. First, selecting and collecting information. Begitu pentingnya data. Data-data yang kita kumpulkan, ya, kita harus ramu, kita harus olah. Including we read literatur. Jangan malas untuk membaca literatur. Meskipun kita dari kedokteran, kita tidak tabu, kita tidak alergi terhadap isu-isu di luar masalah kedokteran. Ya. Kedua, second, observer. Kita akan melihat, kita akan memperhatikan kebutuhan-kebutuhan di dalam melakukan pengembangan sebuah pelayanan kesehatan. 20 years later, 20 tahun yang lalu, pasien kalau dikatakan Anda harus periksa ini, nurut. But now, kita harus berikan alasan. Why? Kenapa kita akan periksa itu? Buat apa saya periksa itu? Dan itu harus dijelaskan, karena itu adalah bagian dari etika kita sebagai seorang dokter. Betul ya, Dokter Valeria? Ya. Dalam undang-undang kesehatan kita harus menjelaskan untuk apa pemeriksaan yang kita lakukan. Kita tidak bisa, saat ini era teknologi, medical equipment semakin modern. MRI is 3 Tesla, 5 Tesla, Dr. Anissa ya, sudah 5 Tesla. Di Malang ada 3, nah, paling tinggi 3 Tesla. Tapi apakah headaches kemudian kita rujuk untuk pemeriksaan MRI? Nah, itu harus kita perhatikan. Ya. Setelah kita observe development need, we can planning prototype component and development initial prototype, and kita bisa memproduksi, menghasilkan dulu secara terbatas, dan apa yang sudah kita produksi kita lakukan uji coba, ya, merevisi dulu model-model yang didasarkan dari initial trial. Kita tidak bisa langsung menerapkan. Maka ada penelitian-penelitian terkait dengan penggunaan komponen dari laboratorium, ekstrak, ya, penelitian berbahan baku ekstrak. Nah, ini harus kita lakukan sebelum pada akhirnya nanti kita akan memberikan, ya, memberikan kepada pasien, dalam hal ini healthcare. Kita sosialisasikan, carrying our dissemination to various parties through publicity and other discussion methods. Ini adalah 10 langkah secara umum terkait dengan research and development. Ya. What are the main characteristic of research and development? First, we are studying research finding. Kita harus temukan apa-apa yang hal mendasar, ya, mendasar yang perlu kita kembangkan, kita teliti dan kita kembangkan. Dan selanjutnya, we developing the product. Kita mencoba untuk membuat produk-produk dasar, ya. Dan produk-produk itu kemudian kita tes di lapangan, field testing, ya. Kita coba, dan pada akhirnya kita bisa terapkan. Dan sebelumnya tentunya kita merevisi, revise kekurangan-kekurangan yang kita temukan pada field testing. Barulah kemudian kita bisa implementasikan terhadap pelayanan kesehatan yang kita lakukan. Research and development have a 4 model. Saya terus ke sini saja. That's it. First model, the namely is unidisciplinary. Pada model ini kita hanya akan mengembangkan riset berdasarkan satu bidang ilmu, ya. Satu bidang ilmu dan tidak terkait. Dulu mungkin kita begitu. Nah, berikutnya multidisciplinary model. Ada banyak keilmuan yang berdampingan dengan kita, ya, misalnya family medical school, health science, and psychology, but sendiri-sendiri, masih sendiri-sendiri untuk menyelesaikan one problem, no collaboration. Third model, interdisciplinary. Nah, that model is collaboration. But collaboration is step by step. First problem is finished. We find a second problem, we discuss, we collaborate, they finish it, and then seterusnya. And fourth model, totally collaboration, interception for the one's conclusion. Stunting, what the model that we use? I think we cannot to undisciplinary. Tidak akan pernah bisa kita menyelesaikan stunting hanya dari ilmu-ilmu kedokteran. Maka kita tidak bisa bicara stunting, menyelesaikan stunting hanya dari ilmu kedokteran atau dari ilmu kesehatan. Oh, stunting karena orang tuanya tidak memberikan asuhan yang tepat, maka anaknya tidak diberikan makan yang benar. Oh, kita tidak pernah tahu apakah ada underlying disease dari anak tersebut. Yang tadi Prof. Ignatius sudah menyampaikan bahwa stunting tentunya kita mulai dari saat ibu itu mengandung. Kita kalau menemukan stunting sekarang, it's too late, terlambat. Seharusnya kita belajar faktor resiko, risk factor. What the risk factor, and then maternal bisa memberikan melahirkan anak dengan berat badan lahir rendah yang merupakan salah satu faktor resiko terbesar untuk kemungkinan next akan jadi stunting. So, untuk menyelesaikan stunting tentunya kita paling tidak kita menggunakan metode interdisciplinary research and development, bergandengan tangan. Kita selesaikan ibu hamilnya dulu. Dari sisi medis, ibu hamil harus kita jaga, jangan sampai terpapar atau sering terpapar penyakit. Dari sisi keluarga, psikologi harus dikuatkan. Bagaimana psikis dari seorang ibu? Dia harus menerima satu perubahan. ibu yang aktif bekerja, kemudian setelah usia kandungan 7-8 bulan mungkin sudah mulai bekerja sebentar capek. That's right, Dr. Anissa? Ya, 7-8 bulan sudah mulai capek sehingga ada perubahan. Nah, mungkin dari segi ekonomi harus diselesaikan juga. Nah, kita selesaikan satu problem ibu hamil dan problem saat ibu melahirkan. Bagaimana ibu melahirkan dengan selamat, dengan aman, sehat, dan dari ekonomi, nah, dari BPJS biayanya murah, ya. Dan pada saat anak yang dilahirkan as not perfect, orang tua harus menerima. Karena kalau seorang ibu mungkin melahirkan anak yang tidak dibayangkan sebelumnya, pasti akan kaget. Nah, ilmu psikologi masuk di sini. Nah, sehingga setiap tahap, every step, semua ilmu akan masuk di situ, akan bergandengan tangan. Selesai stunting, Prof. Ya, oke. Nah, ini kalau kita berbicara masalah health research and development, ya, tentunya penelitian dan pengembangan di bidang kesehatan mengacu pada satu proses, ya, yang ini tidak bisa dihindarkan bahwa ini adalah masalah kesehatan masyarakat, ya, dan ini harus kita akui bersama, gitu ya. Dan untuk melakukan research and development pada bidang kesehatan, health research and development, maka kita harus melalui tahapan-tahapan. The first step, basic research. We must understand two causa, development and treatment. Kita tidak akan bisa melanjutkan penelitian dan pengembangan without we don't know about a causa, penyebabnya. Untuk mengetahui penyebabnya, tadi itu kita berkolaborasi. Bidang ilmu harus bergandengan tangan. After we do the basic research, then we applied research. Kita lakukan penelitian terapan. Apa yang kita temukan di situ, kita aplikasikan. Dan jangan lupa, ada etika medis, ada kajian legal aspek yang harus kita perhatikan. Kasus pertama yang ditampilkan Dr. Vanita terkait dengan surat keterangan sakit, betul ya Dok ya? Hati-hati teman-teman sejawat sekalian, jangan mudah kita memberikan surat keterangan sakit, ya, karena kita bisa ditanya, apakah Bang betul sakit? Nah itu. Pada saat kita melakukan penelitian kesehatan dengan melakukan research and development, banyak manfaat yang kita, so many benefit, improving quality of life, pasti, ya, karena penelitian dan pengembangan kesehatan, research and development for health sangat luas aspeknya. Ya. Kita akan temukan the new treatment, ya. Kalau dulu misalnya orang divonis kanker, itu sudah kita tidak bisa melakukan apa-apa. We can do it anything. Just palliative care. Nyeri, kita tangani nyeri. And the people go to traditional treatment. In Indonesia called the disuwo. Di jampi, what in English, jampi. no word for English. Jampi disuwo, ya, traditional medicine, not bukan yang batra menggunakan pengobatan dengan daun-daunan, bukan, tetapi pengobatan supranatural, supernatural medicine tidak ada dalam undang-undang kita ya. My regulation, Indonesian regulation is nothing. Oke, ya. Kita tentunya akan mengembangkan obat-obat dan terapi baru, dan tentunya itu akan memberikan kesempatan untuk memiliki kehidupan yang baru. Quality of life meningkat. Ya. Ya tadi orang kanker, it's okay. Kenapa? Ada obat baru, ada temuan baru. Ya, tentunya itu semua melalui research and development. Ya. Kita akan menuju pengembangan produk baru. Banyak sekali obat-obat baru yang sudah ditelurkan oleh para peneliti. Tapi tentunya kita tidak bisa semata-mata mengembangkan obat-obat itu kalau obat-obat itu belum mendapatkan izin edar. Nah, nih hati-hati. Ya, rekan-rekan, banyak sekali obat-obat yang mungkin kita katakan vitamin, ya, vitamin, suplemen, gitu ya, dan itu diberikan kepada pasien, apalagi dengan suatu promise, suatu janji kepada pasien, wah ini bisa membuat lebih cepat sembuhnya. Begitu tidak terjadi, pasien akan melaporkan KUHP 1365. Nanti urusannya dengan Dr. Valerina. Kita dilaporkan bahwa merugikan pasien karena janji dokter tadi. Ya, dengan pemberian suplemen A, B, C akan cepat sembuh, cepat pulih. Ya, tapi ternyata tidak. Maka kita bisa dituntut di situ. Ya, berikutnya bahwa what the benefit, kita akan bisa menegakkan diagnosis dan menyelesaikan masalah kesehatan lebih baik, ya, lebih baik. Tentunya dengan penelitian-penelitian yang tepat, basic research, apply research. Ya, itu harus kita jalankan dan juga ditunjang oleh pengetahuan. Nah, kita harus selalu belajar, kita harus selalu mengembangkan ilmu kita, ya. Dan bagaimana kita melakukan perawatan. Palliative care sekarang menjadi satu hal yang baru, terutama juga untuk kasus-kasus gerontologi, Prof. Ya. Kita tidak bisa menghindar dari usia yang semakin muda. Usia kita semakin muda ya. Rambut kita jadi hitam, jadi putih kan tambah muda. Jadi warna gelap menjadi putih. Nah, itu menjadi muda. Maka bagaimana kita bisa merawat masyarakat kita yang sudah berumur. Insya Allah kita akan mendapat bonus demografi, betul ya Prof ya? Nanti bonus demografi. Penyakit-penyakit menular di Indonesia, communicable disease di Indonesia belum tuntas. Buktinya apa? TB masih banyak, HIV semakin merajalela, dan semuanya terkait dengan behavior. Ditambah lagi sekarang non-communicable disease, cardiovascular disease, catastrophic disease yang akan membebani biaya pelayanan kesehatan. Kasus kardiovaskular semakin banyak, Dr. Valerina ya. Ya. Dan usianya semakin muda. Bahkan PJB, penyakit jantung bawaan, mungkin semakin banyak sekarang. Betul, Dok. Nah, apakah ini ada kaitannya dengan ibu hamil tadi? Nah, jadi sebenarnya satu kasus, satu kondisi itu kalau kita belajar itu akan banyak kedepannya bisa menimbulkan banyak problem, stunting, epilepsi, autisme, penyakit jantung bawaan. Apakah itu nanti akan terjadi manakala kita tidak bisa mengelola seorang ibu hamil dengan baik? Ya, jangan lagi kita menyalahkan takdir. Ya, jangan ke arah takdir dulu. Mari kita berupaya untuk menyelesaikan itu. Oke. Ya, sangat penting tentunya health research and development. Ya, jadi saya percepat saja supaya nggak terlalu lama. Ya, bahwa dengan health research and development yang baik, maka akan menurunkan angka kematian, akan menurunkan angka kesakitan, dan tentunya membuat usia harapan hidup semakin tinggi. Saat ini Indonesia usia harapan hidup 73 tahun. Yang tertinggi adalah from Japan. Japan 85 ya, 85 tahun. Penduduk Jepang yang jadi masalah anak SD-nya kurang, maka banyak elementary school is closed in Japan. Okay. Health research and development has a multi-layer effect. Ya, akan memberikan efek yang sangat banyak. Ya, ini manfaatnya, dan tentunya paling utama adalah menurunkan angka kesakitan sehingga kita bisa mewujudkan tujuan pembangunan kesehatan nasional RJP, rencana pembangunan jangka panjang 2025 ya Prof ya. Nah, itu akan semakin optimal. Ya. Proses apa yang bisa lakukan? Maka tentunya kita harus understanding the health need of a community. Kita harus memahami apa kebutuhan dari komunitas kita. Kita sebagai dokter, kita sebagai pelayanan kesehatan, kita harus melakukan analisis situasi dulu. Apa kebutuhannya? Kebutuhan di Malang berbeda dengan kebutuhan di Jakarta, berbeda dengan kebutuhan di Papua. Ya. Tidak bisa kita samakan. Kebijakan kesehatan dulu lebih banyak yang top down, but now bottom up. Ya, itu contohnya Prof. Ignatius sekarang berada di Malang dalam kaitannya dengan SDGs. Maka Prof. Ignatius juga akan menggali potensi apa yang ada di dalam daerah di Malang, dan khususnya di University Muhammadiyah of Malang, kontribusi apa yang bisa diberikan oleh Universitas Muhammadiyah Malang. Ya, oke, dan ini tantangan ya, tantangan terhadap health research and development, bahwa masih banyak ya, kalau kita berbicara tentang penduduk yang tidak mampu. Nah, rasanya apain sih ngurusin penduduk yang miskin gitu, padahal banyak problem yang dihadapi oleh mereka tentunya di bidang kesehatan, dan ini perlu harmonisasi ya. BPJS Kesehatan merupakan bagian dari program harmonisasi antara penduduk yang mampu dengan penduduk yang tidak mampu. Kita gotong royong, saling mendukung ya. Actually tidak ada yang pengen kita sakit ya. So jangan mengatakan kalau saya tidak sakit saya dapat apa dalam sebuah konteks pelayanan kesehatan berbasis insurans ya. Kalau Anda tidak sakit, Anda dapat apa? Dapat doa dari orang-orang yang sakit ya. Semoga kita tetap sehat dan memberikan tubuh jiwa kita untuk bisa membantu rekan-rekan kita yang sakit ya. Sakit meskipun dirawat di VIP udah enak gitu loh ya. Saya meskipun di VIP tidak bayar, saya pilih jalan-jalan makan nasi pecel ya.
I'm sorry Dr. Febri, time's only 1 minute left.
Oh, 30 second. Oke, fine.
30 second.
Oke, apa menjadi kata kunci rekomendasinya, bahwa we need a data ya. We collect the data for the health research and for the user research and development. We need data. Kelemahan kita sekarang adalah data kita sangat-sangat lemah dan tidak lengkap. Maka tugas kita adalah bagaimana nanti ke depan kita bisa mendapatkan data, ya, dicatat, dan data itu bisa menjadi kajian untuk melakukan research and development, dan kita akan berkolaborasi dengan ilmu-ilmu yang lain, bidang yang lain, sehingga semua kasus-kasus problem masalah kesehatan bisa kita selesaikan dengan baik dan tidak akan muncul lagi. Pandemi COVID serang sudah insya Allah selesai dan tidak akan lagi ada pandemi COVID atau penyakit-penyakit yang lainnya. Oke, saya rasa itu ya, bahwa kita tentunya akan mendapatkan ya bahwa penanganan kesehatan akan secara kompleks membuat masyarakat akan puas menerima pelayanan kita. Ya, jadi tidak ada lagi yang mengatakan bahwa BPJS itulah murahan. No. Ya, BPJS itu sangat mendukung dan insya Allah sangat bermanfaat untuk kita. Ya, 1 menit. Nah ini sorry. Ya, jadi apa keuntungan? Nah, tentunya tadi itu masyarakat akan puas. Ya. Kita bisa melihat kasus secara luas, ya, tidak hanya pada satu sudut pandang seperti kita melihat kuda memakai kacamatanya. Ya, kenapa kuda itu bisa lurus, ya, tanpa kita pegangi, padahal kalau kita mobil harus puring, harus balance dengan biaya yang ratusan ribu, but horse without spurring, without balancing, dia lurus. Kenapa? Karena dia pakai kacamata kanan kirinya. Kalau kali kekangnya tidak disentek ke kanan, dia nggak akan belok ke kanan. Ya, dia nggak akan berhenti kalau tidak ditarik. Nah, itulah kuda. Maka kita jangan jadi kuda yang memakai kacamata. Kita harus menjadi pelayanan kesehatan yang bekerjasama dengan yang lain, ya, dan kita bisa melihat itu problem kesehatan itu secara luas dan menyeluruh. Kemudian, dan ini peluang untuk penelitian, karena dana-dana penelitian sangat banyak disiapkan oleh pemerintah Indonesia. Ya, mungkin yang mau sekolah ke Malaysia bisa ketemu Prof. Husni. Ya, tentunya akan ada dana-dana penelitian. But we have a weakness. Kita punya kelemahan. Apa itu? Seringkali kita hanya berpikir pada satu skop saja. Pada saat kita bekerja sama, kalau kita tidak satu frekuensi, maka nggak akan ketemu kita. Misal, saya bekerja sama dengan Dr. Valerina, beliau adalah ahli jantung. Tapi kalau beliau tidak mempunyai satu pemikiran konsep bahwa ada faktor underlying disease di balik itu, kejadian penyakit jantung bawaan, maka kita tidak akan nyambung, kita tidak akan selesai. Nah, maka kita harus satu visi, satu pandangan, satu misi. Dan itu tidak mudah, ya, karena seringkali ego masing-masing departemen, each departemen sulit digabungkan. Untuk itu kita perlu menurunkan ego kita, ya, untuk kemaslahatan umat. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Febri, for your insightful presentation. Please, audience, now it's time for the Q&A session. I will, for the participant, maybe you want to speak in Gado-Gado language, in Indonesian or in English. For the participant, would you like to ask? Please raise your hand. Bisa angkat tangannya, perkenalkan diri, kindly introduce yourself, your affiliation, and mention who is the question for, then state your question. Please wait for the microphone to your area. I open 2 questions for the first Q&A session. Maybe from left. One from left area and second one. First from the one in black suit.
Okay, thank you, Dr. Anissa, as a moderator. My name is Muhammadiyah from Medical Student Faculty Malang. I want to ask to Dr. Valerina, ED. First of all, I have permission to ask question in bahasa. Tadi sempat dijelaskan mengenai dan disinggung sedikit mengenai potensi masuknya dokter asing ke Indonesia. Nah, maka kami sebagai mahasiswa kedokteran yang nantinya insya Allah akan menjadi calon dokter begitu, itu tentu akan merasa dengan masuknya dokter asing itu jadi bagi kami atau menjadi saingan begitu dengan masuknya dokter asing itu. Nah, yang ingin saya tanyakan bagaimana perkembangan atau prospek masuknya dokter asing ke ini dan bagaimana standing atau pandangan ID dan juga pemerintah dalam menyikapi hal ini. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Is there one more question from right audience, right area? Oh, Prof. Husnul. Prof. Husni. Please, Prof. Husni.
Assalamualaikum. Izinkan saya juga berbincang di dalam bahasa gado-gado ya. Kalau di sana kita panggil rojak Singapura. Saya nampak satu kesinambungan ya di antara tiga-tiga presentation, which actually opens my eyes. The advantage is you are against the backdrop of a national insurance. Now it so happens that my interest is on social health insurance research in Malaysia, and my supervisor is the advisor to the Indonesian government, which is Professor Aljunied. So we are working in the interest of the Malaysian healthcare transformation, which I presented last year. Professor Ignatius, you have actually opened my eyes here. On a stunting subject, you are going to a whole of government, whole of systems policies. When I first saw your background, your eco-hydrology, so I was wondering what's a man doing all these things, but I see your application in a bigger role, and I think what you make is a very important statement. You are mapping the entire situation in various levels. Very important way of doing things, which I really appreciate. Dr. Valerina, we are all in the same things. It's all ethics, it's all the professional conduct. What our third speaker, my good friend, has presented is what I presented to my government last year, which he actually accepted, what you call hook, sing and sinker. Tetapi kita sudah tukar Menteri Kesehatan yang baru, jadi I still have another step to go. Now, speaking as Wonka President for the Asia Pacific region, the way forward is integrated healthcare, which many countries have seen in Brazil, in Taiwan. People have been in touch with as part of the research, which Wonka is very much involved. Jadi, what I see you should be doing now is you have the advantage of a system which we want to learn. Social health insurance is my personal interest. How can you elevate your national health insurance into an integrated service which covers all aspects, the whole of government, whole of systems approach? That is probably going to be something, a fantastic achievement that you're going to be able to do. None of us can work in silos anymore. You know, like you're a cardiologist, I'm a primary care physician with interest in health financing. Professor Goh is also a family physician, we've been friends. I have been friends with Professor Ali Gofran since 2006. Unfortunately, I have not been able to see him. So today, three of you have opened a bigger vista, a bigger horizon, which, if you can, these integrated service systems, Wonka, of course, feel that being primary care doctors, we insist on vocationally trained primary care doctors. You can't just enter someone to the system. And someone who works with these other disciplines. And for every level of service, you have your insurance coverage. And you can do that on those, like what you're saying, stunting. I think you're going to achieve a fantastic thing. Itu saja. Thank you.
Thank you, Professor. Maybe from the speaker, from first. Then one more. Okay, I open one more question.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. I am Vinta from Hang Tuah University. I would like to ask Professor Ignatius related to stunting. You mentioned that we should have a model for stunting management. Do you think that we should have one model that can be applied in any condition in Indonesia? Thank you.
Maybe from the three questions and also commentary from Prof. Husni, maybe I would like to give first question for Dr. Valerina. How about tantangannya ya, bagaimana pandangan IDI terhadap masuknya dokter asing?
I would like to answer in English first. So for foreign doctors that come to Indonesia to have practice here, of course they have to follow the regulations that rules in Indonesia, just like Indonesian doctors. So I think for collaboration to make a good health system, and of course to treat patients, I think we have a companion from other country to give insight to other doctors that study in Indonesia. So you shouldn't, in my opinion, you shouldn't think that the other doctors from foreign country as competitors. I think you should you should emphasize your skills, your knowledge to become a great doctors, and you can have a collaborations. I think among us as an Indonesian doctors, more doctors are great to make a better country, and because we have a lot of things to do, not only for practice, not curative and treatment, also for the promotive and rehabilitation. Jadi buat adik-adik yang masih muda, saya rasa tidak semua kita anggap sebagai suatu problem ya, tidak kita semua anggap sebagai masalah, tapi itu justru untuk memacu kita untuk mengembangkan diri kita sendiri, baik tidak hanya untuk dokternya saja, tetapi sebagai institusi dari pendidikan dan tentunya juga pelayanan kesehatan untuk membentuk dokter-dokter Indonesia di masa datang agar bisa menjadi dokter yang kompetitif ya. Jadi saya rasa itu bukan suatu ancaman, tetapi juga opportunity buat kita untuk bisa berkolaborasi. Ya tentunya kita harus mempersiapkan diri. Itu yang pertama, dan sekaligus menjawab pertanyaan yang kedua, regulasinya sama. STR, SIP, mungkin for the competences they have, mereka prakteknya kan based on the kompetensi. Jadi sebagai dokter umum tentunya mereka harus mengalami persamaan dulu, sama atau tidak. Contohnya kami di kolegium kardio, bila mana ada lulusan kardiologis dari other country gitu ya, mereka mau masuk di sini, mereka orang Indonesia SPJP mau praktek di Indonesia tapi lulusan Filipina, dia harus diuji dulu oleh kolegiumnya. Jadi saingan saya rasa bukan hanya dari dokter asing, tetapi juga dari
lulusan-lulusan dari luar negeri. Jadi itu kesempatan buat kita untuk mempersiapkan diri, baik sebagai praktisi klinis, juga sebagai universitas tempat pendidikan, dan juga tentunya provider dari pelayanan kesehatan. Kita harus siap-siap. Itu untuk langsung, oke. Thank you, Professor, for your insight. Actually, for stunting itself, I would like to discuss about the stunting first, because the Professor Ignatius already mentioned that stunting is not only about the health system, not only for curative, but also beyond that, we have to make a great system to provide the food itself, right? How to prepare the mother, the pregnant mother, about the knowledge, how they can give the babies the great parenting system, not only about the food, but also direct breastfeeding. I think we have to make a campaign about those things. And now for national health insurance, because of the cardiologists that make the first apa namanya, pengeluaran itu apa ya, expenses. Cardiologists, because of the heart attack, is become the global burden for in Indonesia also. So the cardiologist was assumed to be the great expenses in cardiovascular system and disease. So now the Kemenkes, Ministry of Health of Indonesia wants to give the promotive and prevention first, including to the integrated health system, starting from the primary health care, and then they make programs, I believe, for the primary health care, for the midwives, and also for the babies. But as we know, it's really, I think not only in Indonesia, almost in the Southeast Asia country, that promotive and prevention is also make a big problems. They want to reach the fastest way to become healthy. So curative and treatment is also a great aspect from their opinion. We have I think we already have an integrated national health insurance. Ministry of Health also make a changing of regulations, just like what I said in August last month. They make a changes in the nomenclature of the disease, and they make changes of the claim, and also they ask for not only from the vertical hospital, but also from the regions hospital. And yes, I think the promotive prevention is still the main goals of compared to the curative and rehabilitation, and it's still our problem too. But thank you for your insight.
Thank you, Dr. Valerina. Maybe Professor Topo.
Okay, thank you, Professor Husni. Very interesting your comment. Yeah, basically, I just try to give the overview of the problem. Basically, yes, I am a director of Asia Pacific Center for Eco-Hydrology. So concerned about basically to wash system, yeah, water sanitation and hygiene, and how we can support to overcoming the problem of stunting prevalence in Indonesia, still quite high as I mentioned before. So, but the problem is in our country, in Indonesia, I don't know in Malaysia, still quite complex problem, because many things inside related to regulation, as you know, as I already mentioned, food system, health system, protection, accessibility of foods, etc. That's why we try to identify, and we also try to connect each parameter, each factor, and how to. I would like to also connect it to the second question. We try to make kind of models how to reduce this problem, because stunting is if the stunting is there, is quite difficult in fact to overcome or to come back again. That's why, as already mentioned by our colleague here, that it is important to avoid stunting to be done, in fact. That's why we try to identify what parameter included, related, and to make a model, ya Mbak yang dari Hang Tuah. Memang ya kalau ditanyakan adakah model, memang belum ada model yang komprehensif. So we try to harmonize and to make a model, ya. Saya justru men-challenge tadi ngobrol-ngobrol untuk mungkin fakultas kedokteran itu mungkin bisa membuat model-model berdasarkan kajian, karena data-data stunting, ibu-ibu yang pregnant dan sebagainya itu kan melalui konsultasi, ya, gitu ya. Itu yang waktu saya membuat, jadi kebetulan Bapak Ibu sekalian, saya waktu itu sempat ditugaskan menjadi koordinator nasional PRN, ya, yang prioritas riset nasional itu khusus penanganan percepatan penurunan stunting. Bahkan saya juga terlibat untuk menyusun yang itu, perpres penurunan stunting itu, saya dilibatkan untuk membahas itu. Lah, kemudian begitu kita lihat, lah ternyata itu tadi, kita ternyata tidak bisa samaratakan untuk seluruh kawasan Indonesia. Karena memang berbeda, ada yang itu tadi saya sudah sampaikan dalam presentasi saya, ada yang resourcesnya sangat minimal, informasi yang enggak ada, datanya enggak ada. Tapi ada wilayah yang sebenarnya di wilayah-wilayah perkotaan gitu yang resourcesnya sudah sangat banyak, tapi kejadian stunting ada juga. Nah, di waktu-waktu yang lalu kecenderungannya kita samaratakan sehingga permasalahannya tidak selesai. Sehingga waktu itu pada saat saya menjadi koordinator tim itu merekomendasikan kalau begitu harus dibagi, paling tidak dibagi 3 lah, yang mungkin low, middle, sama high dari sisi resources. Kemudian kita membuat model tadi untuk penanganannya lebih efektif dan cepat selesai, kira-kira gitu. Soalnya misalnya dari yang memang sangat minus tidak bisa disamaratakan dengan yang mungkin sangat bagus walaupun ada stunting juga. Lah kemudian kita bergerak bersama-sama tetapi dengan cara yang berbeda. Itu yang kita butuhkan. Apalagi kita tahu tadi problemnya sangat kompleks, mulai dari remaja menginjak dewasa itu ternyata berpengaruh perilakunya tadi. Nah, ini tidak bisa disamaratakan. Daerah seperti NTT yang paling tinggi, ya hampir 40, lebih dari 40%, berbeda dengan mungkin wilayah barat yang sama-sama ada stunting tetapi perilakunya berbeda, tidak bisa diperlakukan dengan cara yang sama untuk mengatasi problem stunting tadi. Dan saya berharap betul dalam komunitas para dokter yang notabene mestinya calon-calon ibu yang hamil itu kan berkonsultasi, ya mungkin belum semua barangkali ya, karena konsultasinya kadang-kadang tapi paling tidak ke petugas kesehatan lah. Itu bisa membantu gitu ya, kemudian mengembangkan modelnya harus bagaimana, sehingga ini menjadi concern kita bersama. Jadi kalau ditanya Bu, memang ya mungkin Ibu bisa memberikan kontribusi nanti ya. Intinya kita harus bangun model bersama untuk mengatasi. Oke, mungkin itu, thank you very much. Thank you Professor for your concern, thank you.
Last but not least, Dr. Febrio, maybe there is other addition and complementary.
Conclusion. Okay, Bagaimana dengan dokter asing? Menambahkan Dokter Valerina. Kenapa kita takut? Apa yang kita takuti? Ini rumah kita. Maka jangan takut untuk menjadi dokter di rumah kita sendiri. Sejauh dokter dari luar, kita kolaborasi, ya. Ilmunya, ayo kita kolaborasi. Kita tidak perlu takut. Satu yang harus Anda pegang adalah kompetensi. Dan di dalam kompetensi itu ada satu hal yang paling penting. Paling tidak menurut saya. What's that? Communication. Komunikasi Anda baik, Anda tidak akan takut tersaingi. Artinya tersaing apa sih? Anda nggak punya pasien, ya kan? Nah, kalau komunikasi Anda bagus, pasti Anda ke pasien. Sebagai contoh gampang. Kenapa sih kita itu potong rambut pada satu orang nggak mau pindah? Kenapa? Karena kita percaya. Nah, kalau kita nggak percaya, duduk di kursi, potong rambut, berkeringat kita, takut, tak sesuai. Jadi jangan takut. Kompetensi, komunikasi. Oke. Dokter Twinta, ya, from Hang Tuah. Mari dok, kita buat model untuk penanganan stunting di Indonesia. Ya. Monggo dok, kita berkolaborasi. Kebetulan saya ada tempat untuk penelitian dan saya sedang membuat model, paling tidak 2 model. Satu penanganan stunting di area pegunungan dan satu di area dataran rendah. Ternyata itu berbeda. Ya. Mari kita berkolaborasi. Ada dokter Olan di sini, dokter yang lain, ya. Nah, jadi stunting insya Allah akan menjadi amal kita, ya, penanganan stunting menjadi amal kita untuk menjadi dokter yang lebih baik. Oke, thank you Dr. Anissa.
Okay, due to the time limitation, unfortunately we have to end this session. Thank you for the speakers, for the inspiring presentation, the participants for your kind attention and engagement. Now I will return the floor to MC. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you for Dr. Anissa, the neurologist, as a moderator, and thank you to all the speakers, the great speakers. We have a great presentation and interactive discussion. One more time, we give applause to all speakers today. Okay, before you go to your round table again, please to take a photograph. First, we invite Prof. Go and also Prof. Husnui to take a photograph with on the stage. Mohon bantuan panitia untuk ya, Dr. Devri di sini aja. Ya. Also, please. With the okay. Okay, also for Dr. Mehdi, please welcome on stage, Doc. Yeah, to take a picture. Oke, panitia dikasih aba-aba ya. Oke, Dok, Prof, say 1, 2. Oh, Dr. Bayat. Oke, please welcome on stage too, Dok. Oke, give it code 1, 2, 3, cheers. Ya, oke. One more time. Okay, thank you to all the speakers. Thank you for Dr. Medi, Dr. Rubayat, Dr. Anissa. Okay. Okay, thank you so much to all the speakers. Please have a seat again in your round table. And for the next session, this is the moment that we are waiting for. This is announcement for the best oral presentation. Was heartbeat time. We will announce that for the winner of the best oral presentation, we have 3 winners and drum heartbeat. Yeah. Okay, the first goes to Dr. Winta Diar Savitri, MSc, PhD, FISPH, FISGM. Maybe for Dr. Winta or the representative for the Hang Tuah University, please welcome on stage. And for the best oral presentation, the next best oral presentation goes to Dr. Minarni Wartiningsih, Magister Health of FISPH, FISGM. Welcome on stage, Doc, or maybe the presentation from the Ciputra University. Okay, and the last best oral presentation we will give for Dr. Medi Setiawan, MD, internist, Finasi. Welcome to our medical faculty, Dean. Okay, please welcome on stage, Doc. Okay, congratulations to all the winners of the best oral presentation. Okay, give applause for the all winners today. And please welcome the head of the committee, the Dr. Rubayat Indradi, to give the certificate to all the winners. Okay, take a minute to take a picture. Okay, give applause. Congratulations. And also for Dr. Minarni from Ciputra University. Thank you, Doc. Congratulations. And last is for our Dean, Dr. Medi Setiawan. Yeah, give applause. Yeah. And say hooray. Okay, all together. Okay, thank you all the winners. Have a seat again to the round table. Okay, now we are at the end of the event of the closing ceremony. And for the closing ceremony, please welcome the head of the committee, Dr. Rubayat Indradi, Magister of Occupational Health. It's time to give closing remark. Time is yours, Doc.
Okay, thank you Dr. Anissa. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon all of the participants, all of the speakers. On behalf of the Dean, on behalf of the Vice Sector, on behalf of the LPPI UMM, I would say thank you very much for your participation, for your active participation, and also thank you for the sharing, knowledge sharing, and then for the expertise from the expert. We have 7 speakers. I hope this conference today we will get the benefit to have post-pandemic era, and then we will have global health challenge and innovation. So many innovation, so many collaboration between institution, and then we will have good health, and then we will practice the doctor for promotive, preventive, curative, and rehabilitative. Once again, thank you for your coming in Rayz UMM Hotel speakers, Prof. Husni, Prof. Goh, Dr. Febi, Prof. Ignatius, and then Dr. Valerina, and another speaker. I'm sorry if there still lack of from the committee, from our presentation maybe, and another staff in the conference. Sorry, and then thank you for the team for the hard working to have this conference this day. Actually, yesterday we start in oral presentation, and we get the best oral presentation. Once again, congratulations for 3 winner of best oral presentation. I hope this will be very benefit for us. Thank you. I'm sorry, and see you on the next year. I hope we will meet again on September, on 21st September 2024 on the 4th ICMedH Universitas Muhammadiyah Malang. See you next year. Assalamualaikum warahmatullahi wabarakatuh.
Baik Bapak Ibu sekalian, dengan berakhirnya acara yang ditutup oleh Dr. Rubayat Indradi, maka berakhir pula acara kita hari ini. Terima kasih atas segala kehadiran dan partisipasinya di pagi sampai sore hari ini. Kami dari pihak panitia mengucapkan mohon maaf bila ada segala kekurangan. Kami akhiri billahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. See you next year. Thank you to all professor and all speakers.